That's wet. Oh. Oh, I made it. Hello, 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 my friends. Jill Osborne from the Interstitial Cystitis Network. And hold on, you can now see my missing teeth. I had, look, I'm going to put in my flipper. Hey, I've got teeth. For those of you who don't know, this is my ongoing drama. I had my teeth cleaned and they broke 2 teeth. They were unsavable. So I have to wait 4 months to get implants. All right. Hello, Carolyn from England. How are you, my dear? So it's been, I'm sorry, I'm a little bit late. Literally, you know, when you're caring for the elderly, you're caring for the elderly, and life is challenging for them. So I was ready to go live, and we had a little episode, and I had to go clean. Uh-oh, hold on. No sound on Facebook. I can fix that. All right, testing 1, 2, 3. Facebook, can you hear me? Can you hear me now? Can you hear me now? Still? You should be able to hear me now. Yeah, I got the sound set up correctly. Sound's coming out of this. It's all plugged in. Okay, good. So anyway, normally I try to start these live IC support group meetings at 1 o'clock, but I couldn't because my mom had an accident and I had to go see her up. It is what it is. She's 94 years old. Anne says, can corn silk tea help an IC flare? I might. Worth a shot. Hi, Loretta. I got to keep an eye on her real quick. So my name is Jill Osborne. I'm the president and founder of the Interstitial Cystitis Network. I'm the national IC support group leader. I'm also caring for very, very elderly parents, hence my unpredictable schedule. My purpose in doing these meetings is to make you so strong, so knowledgeable, so informed that no one can mess with you. I want to validate you. I want you to know that you're not alone. I want you to know that you're not damaged goods. I want you to know that there's hope. I want you to know that you have a sister in me, in your IC, and in your pelvic pain struggles. And the great news here is we've come so far. We have such great resources now that we didn't have when I was first diagnosed. And so today, if you're newly diagnosed with interstitial cystitis, we are here to kind of help you along the way. Hello, Diana on YouTube. We're simulcasting right now on Facebook and YouTube. If I'm looking here, I'm looking at Facebook. If I'm looking here, I'm looking at YouTube. Let me go just take a quick peek at her real quick. Okay, Mom, come on. All right. Well, she's brushing her teeth. So normally when I do these meetings, I do a 30-minute little mini lecture. I do, and then I'll take your questions. I don't really have a lecture prepared for today. Hello, Eva. Nice to see you. Hi, Gay. Hello, Loretta. Anne says, can corn silk tea help IC? It could. So the teas, the herbal teas. So I've been working on, hi, Kayleen. I have been working on a herbal tea flare formula. And I have my formula. And corn silk is in that formula. What I could not find is a third party that would make it for us without requiring 5,000 boxes. The minimum order was 5,000 boxes of tea. And, you know, I want a lot of testing. And we've done quite a bit of testing already. I mean, I absolutely have my formula. But what I don't have is the ability to sell 5,000 boxes of herbal tea in 6 months, right? And God only knows how much it would cost. So I'm going to keep looking because I think I have a really good formula for a flare tea, something that will really calm your bladder down. Corn silk is one of the ingredients. Obviously, marshmallow root and chamomile are also ingredients, but there's a couple more, and I'm not going to give away my whole formula because somebody else out there might try to make it. If somebody out there wants to make it and they want to license it for me, power to you. I'd love to talk with you. Kayleen, how are you feeling today? Any improvement? Any improvement at all? I hope you're feeling a little bit better. Okay, hold on. I hear footsteps. You doing okay? Okay. Let me just go get her settled. I'll be right back. All right. Perfect timing. You got an A380 landing, the big plane. So come on. Perfect timing. You got to slide to the left, slide to the left. Good more. Slide to your left. There you go. Okay, so we've got cereal, English muffins, fruit soup. Okay? You're welcome. All righty. Sorry about that, my friend. Sorry about that. You know, she's at this is how my mom walks right now. That's how she walks. A step is an inch. Anne says, what was I saying about teas? I said I've got an herbal tea formula for flares. And I'm looking for an independent boxer to make it for us. The ones that I found have a 5,000 box minimum. And I don't think I can sell 5,000 boxes before they would expire within 6 months. Kayleen says she has 100% movement on her hips, 70% improvement on her ribs. Yeah, baby. Now she's saying I need to improve my posture since that's what's causing the vulvar burning. Okay. I'm going to spend this week bugging my urogynecologist about the other stuff since I'm so scared. It's going to come back. Girl, listen, it's the human body. The human body sheds skin cells. There's no reason to be afraid of the human body shedding skin cells. Don't be afraid of that. It is what it is. You know exactly what to do now. You're fully prepared to handle it if it happens again. Okay. I think you got this, girl. You got this. You are set to go. So, what's happening in the IC world? Here, hold on a sec. What is happening? God, so much is happening right now. It's ridiculous. Like, this girl is tired. It was a big, long week last night with lots of stuff. Hold on a sec. So we got the American Urology Association meeting coming up in a couple of months. That's going to be big. All of our new research is going to be there. We now have neuroscientists studying IC. That's very, 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 very important because we now understand the role that nerves are playing. And you know, so I was doing a Zoom yesterday with some friends from high school, and we were talking about interstitial cystitis because all this time, you know, I know a lot of my old friends were like, oh God, here's Jill with her bladder stuff, right? And there's always a little bit of, I don't know if shame is the right word. Embarrassment is certainly an important word because it's embarrassing when you got something like this going on. And I think a lot of regret because a lot of the things that I wanted to do back then, I really couldn't because I had to stay close to a bathroom. Hi, Diane. Anyway, I was giving her the update. I was giving them the update about subtypes and phenotypes. That we've got Hunner's lesions, bladder wall estrogen atrophy, bladder wall chemocystitis, pelvic floor, pudendal neuralgia, and widespread pain. And I talked about that. I talked about that quite a bit because that's definitely probably my big subtype. Where I've had IC, IBS, vulvodynia. They're all gone now, pretty much. I'm pretty much symptom-free, other than my pelvic floor muscles getting tweaked every now and then. And how bladder therapies for me never worked. Why? Because fundamentally, I have a healthy bladder. It's not my bladder. It's my nerves and my muscles down in my pelvis. And, you know, I love my friends dearly, but I still got the blank look. Like, okay. I could just kind of hear the gears like, oh, what's she going to come up with next? And I was talking very specifically about that group of patients who have widespread pain, multiple pain conditions, and characterized also by very sensitive skin, a wicked sense of smell. And it's always really fun to talk with other patients who they're stunned when I go, so do you have really sensitive skin? Yeah. Can you smell things that other people can't smell and the smells drive you crazy? How did you know that? Oh, I had the same thing. What? You got the same thing? I thought it was just me. Okay. Do you struggle with anxiety? Oh, yeah. Okay. Well, yeah, so did I. Okay. Got it. And once we've got a patient that's kind of in that group, we can, I mean, it's a really interesting, fun conversation because number one, you're validated. You're not alone. It's like, oh my God, there's somebody else who's just like me. What? And there are millions of people just like us. And so this week I was talking with a woman in her early 30s who literally would have just been my twin. Exactly. And so we go over the subtypes, get to subtype 5, widespread pain. Do you have sensitive skin? Yes. Do you have a wicked sense of smell? Oh my God, how did you know that? Do you struggle with anxiety? Yes. Do you struggle with catastrophic thinking? Yes. And it opens up the conversation into a direction the patients are really surprised that I'm going. Because it's like, okay, so today we focus on the concept of cause versus effect. Cause versus effect. We don't want to just chase the symptoms. We need to focus on underlying causation. And in fact, I will tell you, I was working with another patient on Friday who, man, she just wanted to treat symptoms, treat symptoms over and over and over. It's like, wait, I understand you want to treat the symptoms, but we have to focus on underlying causation. We don't just want to treat your symptoms. We want to find the underlying problem and fix it. And she had clearly estrogen atrophy, and it was just, a difficult conversation for her. A lot of people she was very scared to try estrogen and things like that. Anyway, my job as a support group leader is to educate you and open up some new doors and then get you back to your doctor. So anyway, I sent her back to her doctor to have some discussions about estrogen, the safety of estrogen. But anyway, getting back to central sensitization, they're always surprised when I go, have you ever wondered why this happens? Like, why did you get IC, and why do you have irritable bowel, and why do you struggle with sensitive skin? Ever wonder why? I mean, because it's not like you really have all these different diseases. We now know that there's a connection. And the connection is the central nervous system. And what our research is showing now is that for patients who have widespread pain, we have a central nervous system that's been injured, that's been traumatized. And that literally 24 hours a day, that injury has caused your brain to be stuck in fight or flight. That's where the anxiety and the catastrophizing comes. And 95% of the time, the patients are so thrilled for me to give them context. And then to actually go back into kind of trauma, because we now know that for 80% of the kids that this eventually happens to, there's a physical injury. And then for the other 20%, there's a history of bullying or abuse. And I was working with yet another patient this week. On Thursday, Friday, I couldn't do my live support group meeting on Facebook because there were so many coaching sessions. Now we understand why there's a history of abuse for some, but certainly not all patients. And that early childhood abuse can injure the nervous system that can create the foundation for all of this. So the great news here is, as scary as that sounds, we know exactly what to do now. We know exactly how to calm this down. We can calm this down. We can get the nervous system functioning correctly again with some very simple, easy techniques. But ultimately, in the end, it begins first with trying to understand your subtype, and then being receptive to the fact that the things that you might have been clinging to for the last 10 or 15 years or 5 years are really probably not appropriate, especially, for example, if you have a completely healthy bladder wall. Here you are at your doctor, you're crying, you're peeing all the time, it hurts, and you have a cystoscopy, and they go, oh, we don't see anything. With a little roll in the eyes, with the suggestion maybe it's all in your head, right? And then you might have a hydrodistension. You ask for the bigger test, have a normal bladder. Come out of that, the doctor's looking at you funny. Your husband or your partner is like, okay, there's nothing wrong with you, Jill. There's nothing freaking wrong with you. You must like this. I had a friend actually say to me, an old friend from high school, Kathy. She's not a friend anymore. She was with me the day it all began. And one day she said, Jill, I just think you like being in pain. I think you need therapy. What? The audacity. No, I didn't like being in pain at all. I needed to try to understand why I was in pain. And of course, now we know why I was in pain, because I had an early injury that damaged my nervous system, that created this foundation for everything that happened later in my 20s and in my 30s. And now that I know what happened, I can go back down and we can piece by piece calm everything down and get everything functioning normally again. Bladder therapies simply did not work. They do not work for pelvic floor dysfunction. They do not work for central sensitization. And so if you have a healthy, normal bladder, that's great news. Let's take that for what it is. That's a healthy, normal bladder. Awesome. Now we have to look beyond the bladder. So don't be upset if they say your bladder is healthy. Your answer should be, okay, good. I'm going to take that. So if it's not my bladder, what else could it be? I need you to look beyond my bladder now. Let's look and see if we can figure this out. Am I wearing my matching earring? I might not be. I thought I was. Oh well. Hi, Amy. So hold on a sec. Kimberly said, I got hit with clitoral pain. Yep, I know. And I see all at once, handful of months after my husband's cancer diagnosis and PE diagnosis and emergent surgery. I'm guessing stress is my trigger. I've always had sensitive skin. I do struggle with anxiety. I'm finding that working on stress and anxiety tremendously helps. Yes, because when you're under stress, you tighten muscles. And when you keep those muscles super, super tight, what do? They start squeezing nerves, right? They start squeezing nerves. So I'm glad. We shouldn't be offended when somebody says, hey, we got to work on this anxiety. We have to go, yeah, you know what, you're right. Because when you're anxious, your brain intensifies pain. It will only help you to try to work on calming everything down. We got to calm the central nervous system down. We got to calm fight or flight down, etc. I had a little bit of clitoral pain the other day walking. And I can always tell when my pelvic floor is starting to get tight. And so what did I do? As soon as that started happening, I got home, dropped trowel, got my wand, worked on the muscles, and it went away. If you don't work on it, that's a problem. Hey, Barbara. Nice to see you, girl. Nice to see you. Kayleen says, that's what Jill and I were just talking about. Clitoral pain is the worst since it's so close to the urethra. Mine is sensitive and overactive. It's nuts. So in my, let me read you my editorial in our magazine, because I think that you'll find this. It's short. So this is the cover for our new magazine. It'll be at the printer tomorrow. I just have to sign off on it tomorrow morning. So the title of my editorial is Chasing the Tail of IC BPS Treatments. Okay. Oh, this is so interesting. So a physician recently requested the advice from members of the American Urogynecology Society for what he thought was an unusual case. An otherwise healthy 44-year-old woman was complaining of vulvar irritation, urinary frequency, urgency, pressure, and burning that worsens the week before her period. And it's also worse at the end of the day or if she's been on her feet for a long period of time. So let me just say this again. We got a 44-year-old woman complaining of vulvar irritation, frequency, urgency, pressure, burning that gets worse the week before her period and gets worse at the end of the day or if she's been walking for a long period of time. Okay. The responses from the doctors and the physical therapists give me hope for the future of our care. A urogynecologist wrote, quote, this is classic pudendal nerve irritation from pelvic floor dysfunction. He notes that the menstrual cycle, excessive standing, walking, and of course, prolonged sitting irritate the pelvic floor muscles, resulting in more compression of nerves, and that the nerve pain typically worsens throughout the day until they have a chance to recover overnight. But here's a statement that caught my attention. Quote, this is the same nerve pain cycle that often occurs, that often causes bladder and urethral pain and IC. Now, as you know, we are in a transformative moment in the IC world. In the past 30 years, we've come to accept that bladder therapies are generally not successful for the typical IC patient. Why? Because many of us, myself included, have a normal bladder wall. And in recognition of that fact, the updated guidelines for IC state that no bladder disease process is found in the typical IC BPS patient, other than those who struggle with Hunner's lesions or infection. This case perfectly exemplifies the neuromuscular connection that we now believe to be the underlying dysfunction in many IC patients, myself included. And appropriately, pelvic floor physical therapy was recommended as a treatment of choice, perhaps with some muscle relaxants, topical lidocaine gel and or a 3 to 6 month course of gabapentin to calm nerves. So not lifelong, just a slow onset of gabapentin to calm nerves down, and then a slow offset once the nerves are calm to get off of the meds. Botox injected into the puborectalis was encouraged if physical therapy wasn't successful. And the responding doctor concluded, you'll endlessly chase your tail trying to treat for vaginitis. Oh, and suppress your cycle somehow, like with a hormonal IUD, etc. You'll endlessly chase your tail trying to treat for vaginitis. So here, again, we've got an OBGYN treating somebody with frequency, urgency, pressure pain, and vaginal irritation, vulvar irritation, who's going vaginitis, 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 despite the fact that this patient has urinary issues. And as this doctor says, you'll endlessly chase your tail trying to treat for vaginitis. Why? Because it's all about the muscles and the nerves instead. And as we have so painfully learned, we've been chasing our tail trying to treat BPS with bladder therapies as well. This is a true moment of change for patients struggling with pelvic pain and the providers who treat them. And our future is looking very bright. So this is monumental, what's happening. Our challenge now is getting the information to local doctors, because the local doctors don't know about it. They don't. Are they going to come to the AUA meeting? No. Are they going to read the journal articles? No. So we become the educators. That's why I try to write a lot of stuff that you can print out, that you can take to your, like our magazine, that you can take to your doctor, show them the article, or better yet, and they're all referenced with appropriate journal articles. So we can go right back to the journal that's motivated that, right? Hey, David. David says, I was watching a show on the Life Channel called Sex, and it sent me to the ER. The lady, okay, you were watching a show called Sex, sent me to the ER. The lady was eventually diagnosed with interstitial cystitis. Interesting. Very, very interesting. Mary says, what dose of gabapentin is recommended? Honey, that's medical advice that I can't give you. That's something your doctor, I would encourage you to just Google it, look at the lowest dose, and then have a discussion with your doctor about it. Hitatsu says, my urinary incontinence has become much better now. Yeah, baby. Woohoo. I love successes like that. Diane says, neurological sensitivity, and had a cystoscopy 15 years ago that showed bladder irritation and now have estrogen atrophy. Should I have a cystoscopy again to check out the bladder lining? Well, you know, Diane, listen, I don't like guessing. I like facts. And if you think something has changed in your bladder, having an in-office simple cystoscopy is not a bad idea. You know, it's a 5-minute, what I call a looky-loo. They numb your urethra, stick a cystoscope in, take a look around, pull it out, you're done. If you, for example, had your symptoms get much, much worse, if you're starting to bleed, if you've got a lot of blood in your urine, or anything else that is particularly concerning, then that's when your doctor might want to do a hydrodistension with cystoscopy, right? You shouldn't be afraid of testing like that. It's very important that you give a doctor an opportunity to look, so that if, for example, you come out with a healthy bladder wall, we're going to celebrate that. That's fantastic news. Healthy bladder wall. Now we've got to figure out what is going on that's causing these symptoms, right? Hitatsu says, how are my parents? That's why I was a little late today, because my mom slept all night, which is a miracle, and was up at 10:45, but she wanted to go back to bed. So I let her go back to bed, and then she had nightmares. Like, she had really bad nightmares. And so when I was trying to wake her up at 11:30, because she's normally up, you know, between 11:30 and 12:30, she didn't want to get up because the nightmares really scared her. So that's why I was a little late, because I had to, and then my dad fell asleep and couldn't help. So anyway, but other than that, she's just very frail. She's getting very, very weak. It's getting much harder for her to walk. So she'll be in a wheelchair probably within a month, I think. Oh, send me strength. Send me strength. Mary says, do I think walking is bad? Absolutely not. Are you kidding? I did a walk in the rain this morning. I am invigorated from my walk. It's very important that you get yourself outside into nature and move a little bit, because when you walk, you produce natural endorphins, natural painkillers. It's good for your heart. It's good for your blood pressure. It's good for anxiety management. It's good for all of that. Mary says, what do I think about Pilates? Pilates is great. And in fact, we had for many, many years a program called Pilates for pelvic pain. In fact, do I even have it? Here, hold on. Let's see. Yeah, here it is. I didn't have a chance to really change this morning, so you're getting casual sweatpant Jill today. New Dawn Pilates for pelvic pain was created, I don't know, 15, 16 years ago. We sold this for many, many years as a DVD. Tatsu says, no, I'm waiting. She's going to do the toast in about a half hour. You watch. Anyway, they're not making this anymore. At least I don't think they are. We sold a ton of these for patients. Thank you, Renee. These are from my favorite, you know, I'm a gamer. Well, except not so much recently. I used to love computer games, and I love watching streamers. And this is 100 Thieves. I don't know if you can see that or not. 100 Thieves. They have Valkyrie and Courage JD as streamers, and they're very entertaining and fun and happy. So anyway, I watch them and I support them. Okay, getting back to New Dawn Pilates. We have not been able to get these in about 2 years. Let me just see if I can figure out. These were really big sellers for the IC community. They have video. Okay, so they have some videos on YouTube. You might be able to get it at some thrift stores. I honestly, I don't know what happened to, I think her name is Butaccio, right? Jenny Butaccio. I don't know what happened to her. Let's see if it's on Amazon, just out of curiosity. I hope they weren't affected by COVID. So it looks like it's on. Yeah, there's only one on Amazon, and it's used. I'll have to, you know what? I'll see if I can find her. I will see if I can get an update. Hopefully they weren't affected by COVID. Hopefully. We'll cross our fingers. Oh, you guys. You're not going to believe what happened last Sunday. So I did our support group meeting here, right? And you know, Sundays are tricky because all of our big fires have been on Sundays. And I've had to evacuate after doing meetings sometimes. Anyway, so I do our meeting last week and 3 hours, and I'm just ready to just kind of relax and just get mellow. 10 minutes later, my sister called me. Their entire family had COVID. 3 generations, everybody in the family had COVID. Grandparents, grandparents, parents, and kids. They had been COVID-free for 3 years, and now somehow they all got it. And obviously, it's devastating because my sister is my life, you know. I mean, she's the one person I can really count on. I've got two people I can really count on, my sister and my best friend from high school. Yeah. Oh, so scary. And I was like literally in here turning everything off. And she calls and she's very stressed on the phone. And she said, I need you to go to the hospital. I need you to go get our meds. And so I went down to the hospital and got their the what is it called? I forget the name of it, but anyway, the COVID med. And then the very next morning, I got the other call because the son had it now, and said, "Could you please go back to the hospital? We need you to get more meds." And it's like, okay. And it was Janice, if you're listening, my sister's name is Janice. You know, honey, I love you so much. You are my best sister ever. And I would do anything for you. And I said that to you over the phone. And I think you were really, really surprised when I said that. Like, seriously, if you needed a kidney, I would give you a kidney. You're my sister all the way around, and I will do anything I can for you and your family. Just know that 100%. You can always count on me. Okay. I love you. Okay. Remdesivir. Thank you, Hitatsu. That was it. Or Arlene Paxlovid. Okay. Well, it was one of those. It was in an orange and white box. It's just life is so crazy. Life is just so weird right now. Kayleen says, look good, feel good. I've been wearing pelvic friendly joggers to work. We're supposed to be wearing black dress pants with belt loops. Not happening with me. Absolutely. The good news is you can get yoga pants that look like work pants and nobody will have a clue. Georgia said, I had a urology doctor for IC. Then my doctor referred me to my urogynecologist for pelvic floor. Do I need to go back to urology? Well, Georgia, if it depends upon the health of your bladder. It depends upon the health of your bladder. If you have Hunner's lesions, then yeah, you're probably going to need to work with your urologist a bit more. But if you seem to be pelvic floor driven, then the urogynecologist and or a gynecologist should make that appropriate referral to you for a pelvic floor physical therapist, etc. Hitatsu said, are the COVID cases increasing in the U.S.? Well, they stopped monitoring it. They stopped monitoring it. They pretty much, I don't understand. I just don't understand. But they've ended the COVID emergency, even though literally they only fill these prescriptions at the hospital 24-hour pharmacy, and the only people there are people who are getting them for COVID patients. So we have a lot of COVID here. We have a lot of COVID here in my town. Amy said, did I see your post above? Hold on. Amy, where's your post? Kimberly says, many decaf floral teas are okay. I like chrysanthemum tea and peppermint tea myself. If you aren't in a flare, you could always try the tea. Yeah. Amy says, okay, here it is. After seeing my pain management doctor this week and my gynecologist again last week, I've decided to get a hysterectomy. The gynecologist isn't sure I'll get relief of the cramps and the pain, but the pain doc believes it's the easiest thing to do just to rule out pelvic organs. You're going to get opinions of both urologists you see first. Oh, Amy. I mean, number one, how old are you? And you know, one of my best IC friends had a hysterectomy for that reason at the age of 21. And you know, in hindsight, they finally realized it was never her bladder, it was something else, and she permanently lost her ability to have children. So that's not, I don't think that that's the right reason to have a hysterectomy. I think because it changes everything about your life. hysterectomies are they're the most difficult surgery a woman can have, other than obviously a heart transplant or something like that. But it's not necessarily an easy thing to go through. There can be complications. As many patients who've had hysterectomies can say, you don't feel good for about a year. I didn't feel good for about a year. It was like a year after the hysterectomy when I was finally back to normal. I had a lot of pain after the hysterectomy for many, many, many months because I was having pelvic floor spasms. So I don't know of any doctor who would say, hey, let's just take out your uterus and see if that makes it go away. I would rather them actually look at your uterus first. Like, how about having a laparoscopy, an exploratory, to examine the structures from the outside to see if they can find a dysfunction from the outside, like endometriosis. You could even have a D&C where they can look inside your uterus to see if there's anything funky going on in your uterus. But to just cut it all out without, that's thinking from like 50 years ago. I'm very skeptical of that approach. I'm glad you're going to go to a couple of urologists and get a second opinion. I think that that's really important. You need to get this book, and it's free on Kindle Unlimited. It's free. So no excuses. It's free. This book is called Facing Pelvic Pain, a guide for patients and their families. And this is the book that we all needed 30 years ago because it goes through every possible medical condition that can cause these symptoms. It was produced at Harvard. And so there are chapters on what gynecological conditions can cause pain, what male urologic conditions can cause pain, what rheumatological conditions can cause pain, what musculoskeletal issues can cause pain. Like, how can my ureters cause pelvic pain? What GI problems can lead to pelvic pain, etc. And so if they have zero clue as to why you're in pain, you need to go through this chapter by chapter and start taking a lot of notes and start asking a lot more questions. Does that make sense? They've done all except the laparoscopic surgery. Well, listen, my first year, now I think I've shared with you that my first year I had no relief from pain. My pain was off the charts for a good 18 months. No pain care, nothing. And in my head, I was going, this has to be cancer. Nothing else would hurt than cancer. They have to have missed cancer. And so I just flat out asked my Dr. Bennett, my gynecologist at the time, I said, I want you to open me up, do an exploratory. I want a laparoscopy. I want you to look because I think you're wrong. I think I have cancer. And I can still remember his face because he kind of tilted his head and he goes, really? And I went, oh, yeah, absolutely. I want you to look. And I had the laparoscopy. And I was in late September of 1993. I don't regret it a minute. I don't regret it a minute because when I woke up in the recovery room and he had a big smile on his face, he goes, Jill, there's no cancer. You're fine. And then when he did my hysterectomy 25 years later and they looked in my bladder, again. He said, Jill, your bladder is perfectly normal, perfectly healthy. This proves once and for all your symptoms were never coming from your bladder. They have always been neuromuscular for you. So I think it's important to not jump into the full hysterectomy first, but to work your way up there, you know. Did they do a D&C? Renee says, prolapses were my issue with endo and fibroids. Amy, wait, I agree with Jill. Please try other things. Renee, I've tried everything but pelvic floor physical. Wait. Amy, wait. You haven't done physical therapy yet? What? You haven't done the single most effective treatment ever studied? Girl, get your butt to physical therapy and at least have a pelvic floor physical, pelvic floor assessment, and let's just see if your muscles are part of the problem or not, right? You got to go to physical therapy and at least, with our new guidelines are really crystal clear. And that is, they're supposed to check your pelvic floor at your very first appointment with a urologist. And if your pelvic floor muscles are tight, you are to be sent immediately to pelvic floor physical therapy. No hesitation. No hesitation at all. So it is very, very important that you go see a pelvic floor physical therapist and have a proper pelvic floor assessment. As Dr. Weiss says in this book, which I'm just not even keeping in my bookshelf behind me now because I refer to them so much, Breaking Through Chronic Pelvic Pain, right? And this is the master class for all muscle and nerve issues in the pelvis. This is, in my opinion, the best book ever written for our community. And I'm one of the authors of IC 101. This book is better. But this book is focused on muscles and nerves. And it's filled with success stories. But Dr. Weiss, early on in his career as a urologist, he saw that bladder therapies didn't work. He wanted to know why. He was the first urologist in the country to look beyond the bladder to muscles, etc. And in his introduction for this book, he says, listen, Western medicine fails the typical pelvic pain patient. Why? Because doctors play in their sandbox. Urologists stay in the urinary tract, gastroenterologists stay in the bowel and the gut, gynecologists stay in the vagina and the reproductive tract. They don't look at relationships, and they don't typically look at muscles and nerves. But the pelvis is a very small, confined area. There's a lot happening in our little pelvis. You got organs, you got muscles, you got nerves, you got giant blood vessels. And nothing operates in isolation. Everything influences each other. If you have a bladder infection or a yeast infection, you're in so much pain, your muscles will get tight to protect you from that pain. That's called the viscerosomatic reflex. But the far more important question is, can muscles change the way the bladder behaves? And the answer is yes. That if your muscles are so tight that they start restricting blood supply, will your bladder be healthy if it doesn't have good blood supply? Of course it won't. If your bladder is supposed to get 24, 28 units of blood a day and it's only getting 10 because your muscles are so tight, you're now in ischemia, then you're going to have a compromised bladder. And bladder therapies will never fix that. What will fix that is restoring blood supply. And the way we do that is with physical therapy. And of the $100 million put out by the U.S. government to study new treatments for IC, every bladder treatment failed. All of them. Elmeron, everything. Barely above placebo. The one treatment that worked remarkably well was pelvic floor physical therapy. And when that study came out in 2008, the IC world was put on its head, because up to that point, everybody's going bladder, disease. And it was like, wait a second. Then why would working with muscles help? maybe, just maybe, this isn't just a bladder issue. Maybe for some of you, in fact, for 85% of you, it's a muscle issue. There's muscle stuff going on. So Amy, girl, you got to get your tush over to physical therapy and at least have somebody check the health of your muscles, right? Amy says this hysterectomy will be robotic and only one night in the hospital. Yeah, I know, hun, but you're putting the cart before the horse. I was home 90 minutes after I came out of the recovery room for my hysterectomy. So why are they thinking you're going to need to be in the hospital? Galax says, isn't bladder a muscle too? Well, the bladder has a different type of muscle. Your pelvic floor muscles are skeletal muscles. These are muscles that help you move. They help you open and close your leg. They help you balance. They help you walk. The bladder, deep inside of the bladder, or the outer edge of the bladder, on the outside of the bladder, is smooth muscle. It's a completely different type of muscle. That's why if you have pelvic floor spasms, we're going to give you a skeletal muscle relaxant like Valium or Flexeril. But if you're having bladder spasms, they have to give you a smooth muscle relaxant known as oxybutynin. But the most important thing, Galax, about the bladder is that the inside of the bladder is wet. Think about your bladder for a moment. It's the only organ in the human body designed to hold toxic waste. So how can the bladder hold ammonia and acid and urea and all sorts of other irritants for hours at a time and not get damaged? Well, the way it does that is with a really thick, wet coating of mucus. So your bladder is like your mouth. It's a hollow organ covered with a really thick, wet, slippery coating of mucus. And that mucus acts as a barrier and it protects skin. So it prevents the irritants in your urine from reaching the more fragile cells of the urothelium and then eventually the nerves, blood vessels, and smooth muscle. That also makes it more difficult for bacteria to get to those cells to infect those cells. So the bladder is fascinating. It's a fascinating organ. Hi, Dana. Amy says, you've done physical therapy on many body parts without success. 2 urologists and my gyne both said my pelvic floor isn't tight. Okay. Then if your pelvic floor isn't tight, then you've dotted that I, you've crossed that T. And so we move to the next step. And so the next step could indeed be hysterectomy. Georgia says, thank you. If I understand right, urogynecologist for pelvic floor and IC, and urologist for IC. Urologist really for, well, urogynecologist can treat, it can treat quote unquote IC, depending upon your subtype. One is not better than the other. The advantage of a urogynecologist is they're supposed to have really good knowledge of the bladder, as well as really good knowledge of the reproductive tract. So, they're equally good, but I think the urogynecologist is a little bit better placed for women, particularly older women who might be struggling with estrogen atrophy. Galax your doctor diagnosed me with bladder thickening. So you have what we call a fibrotic bladder. So your bladder is like a balloon, right? So at rest, when it's empty, it's small. And then as it slowly fills with urine, it gets bigger and bigger and bigger and bigger and bigger. And then when you urinate, it collapses back down, right? So it's really amazing how the tissue of the bladder can do that. And the way muscle fibers work is muscle fibers at rest are like this. When they are in tension, they're like this. So this is a tight bicep. If I don't pop my bicep, my muscles are like this. If I do pop my bicep, my muscles are like this. So that fibrotic bladder is a thickened bladder wall that's kind of stuck here. I mean, I'm sure that there are other things going on, but I think that that's probably the easiest way for me to describe that. And so in situations like that, and why does that happen? That can happen after injury. That can happen with scar tissue. That can happen if you've been chemically injured through chemotherapy, maybe. If you've used ketamine, something that would have really potentially damaged the bladder wall and left some scars in there. Repeated UTI, that could do it. But sometimes that happens just habitually, where we get comfortable going more frequently. And as we organize our day, we make a lot of bathroom stops, even if we don't need to use the bathroom. And so what that does is that habituates the bladder to be smaller. But so that's why we're going to do a bladder holding protocol, also known as timed voiding, to try to slowly expand the bladder. So that would be if you're peeing every 30 minutes, it would say, okay, go for 35 for a couple of days, then go to 40 for a couple of days, and go to 45 for a couple of days, just to slowly and gently try to get that bladder to stretch itself out again. Here, hold on a sec. Something just came through here that I got to look at. Ooh. All right, I'm going to have to, here, hold on a sec. Let me just email her back. We now have on our store, we have live chat. And we try to get to those really quickly. So let me just, this is just somebody asking about a chair cushion that they have pelvic floor IC and rectal pain with hemorrhoids. And so the cushion that's really ideal for that is our travel cushion, which I should have. Where is it? Let me see if I have it here. Yeah, here it is. Is that it? Here it is. All right. So let me show you. If you struggle with any pain sitting in your crotch, whether it's your urethra, your vulva, your prostate, your testicles, your rectum, if you struggle with hemorrhoids, this cushion is the bomb. Look at this cushion. Now the one we have is actually not like the, it's a different fabric. This is one they sent me to have me look at it. But if you look at the design, you can see that each butt cheek is supported, but nothing is touching your crotch. So this is the ideal cushion for somebody with pudendal neuralgia, rectal pain, hemorrhoids, urethral pain, testicle pain. We had a cheaper one that we sold for, in fact, they were special made for us. We sold many of these all over the world. This is our old bladder and prostate friendly chair cushion. And it too has a groove down the middle. Sorry, the colors aren't very good. Let me see if I can take it out of the cover. Let's see here. Come here. Okay. Okay. This is the old bladder and prostate friendly cushion that the IC Network sold for 20 years. They were made for us specifically for a company by Dynatronics. And they were, again, each butt cheek is supported, nothing touching your crotch. Unfortunately, and these were really cheap. They were like $35. Unfortunately, COVID wiped out the factory and they shut down the factory and the factory's over. It closed. So we cannot get these anymore. So the closest substitute that I have is this cushion. This is a much better cushion than the original one, but it's also much more expensive. It's in the 70s, but it'll last for a long time. Great cushion. So here, let me just... Hold on, the travel cushion. I use it myself when my Hemis are acting up, as they have been known to do. All right. Are you okay, Dad? Yeah, I'm okay. Okay. He says he's okay. Dottie says, hey, I've got good news. Last week I thought I had a flare, but it was a UTI. You're feeling lots better. Fingers crossed I go fully back into remission. Absolutely, girl. Absolutely. Yo, we all have to remember that the human body is wired to heal anyway. Healing always happens. It's always happening. Dana says, what to do if they do see inflammation on cystoscopy? My urogynecologist is just taking a wait and see approach. Reassess this April. He said, no need for the cytology, and okay, if you want, I can give you a referral to physical therapy. Well, you have to remember that the technique itself can potentially irritate the bladder and give you kind of a false signal of irritation. So if they thought they saw inflammation during a hydrodistension with cystoscopy, we now know that when you stretch the bladder turns red and gets little red spots on it. And so a wait and see approach is reasonable. It's reasonable. But if your symptoms are getting worse rather than better, you might want to have a little bit sooner, right? If you have blood in your urine, visible blood in your urine, you definitely want them to take a look. And of course, go have a pelvic floor assessment. Let's see what's going on with those muscles, if anything. I would. Amy said, you had a previous heart attack and type 1 diabetes. Girl, I'm so sorry. Life is complex. And did you see that there was something came out in the last 48 hours about diabetes and, God, what was it? It's interesting. It was a very weird correlation. Diabetes and, what was it? I bet I can find it. Let me just do past 24 hours. It'll come to me. And Marie says, I have frequency issues and I never feel like I empty. I will be going for a bladder test tomorrow and I'm so nervous. I am also getting a CT scan for pressure and pain I feel. Trying to learn as much as I can. And I've started on the IC diet and I've seen some results. Awesome. I'm glad you're doing the diet. That helps us understand to what degree your bladder wall is involved. You know what kind of test you're going to have tomorrow? Is it a urodynamics? Is it a cystoscopy? What's the test going to be? Sherry says, I have an MRN on my lumbar and pelvic area soon. Hopefully they will get an official diagnosis of pudendal neuralgia. Okay. Nerve pain is electrical pain. It feels like pins and needles. It might feel like you're being shocked. You might have areas of numbness. Nerve pain is often positional. You're fine when you stand, but when you sit down, it hurts. When you bend over, it hurts. Galax says, can bladder thickening be really reduced back to normal as it was? It could be. It could be. It depends upon, I think, the amount of scar tissue. We have to try to figure out why your bladder wall is thicker. If you have a copious amount of scar tissue in there, scar tissue is harder to work with. There's no doubt about that. If, on the other hand, you have a fairly normal skin, that it's more of a behavioral, just urinating too frequently, that would be potentially very fixable. And I have a little tiny black floater in my eye. That's so weird. Here, let me go check on the folks. I'll be right back, okay? Hold on. Everything okay? Okay. Okay. Everybody's fine. My dad has GERD, pretty bad GERD, every day. Galax says, I suffer from my floaters too. Yeah, I about a month ago, I spent like 16 hours in a row on electrical devices. And I got a lot of eye pain, especially in my right eye. And when I woke up the next morning, I had this little explosion of light, which was a piece of my retina breaking off. But it's a normal aging thing. And I was at the eye doctor literally 45 minutes later, and they checked my retina. My retina's fine. This is just something that happens as you get older. And so I still have, on that side, I have like a little wavy thing. I was walking this morning and I could see it. That is just this age-related thing there. Mary says, can pudendal neuralgia be cured? Yeah, definitely. If we can figure out what's compromising the nerve, usually a tight muscle or something else like that, and then at the same time, doing things that will directly calm the nerve down. So pudendal neuralgia requires a couple of different things. It requires muscle work. It requires nerve therapy. They might give you topical nerve therapy like lidocaine to calm the nerves at the surface of the skin. See, now he's singing. Now he's singing. They might want to do nerve blocks. They might want to put you on gabapentin. You might want to try palmitoyl as an alamide, PEA. The biggest thing that I've learned about pudendal neuralgia, since I have that too, is stop doing the things which make it hurt. If sitting for a long period of time triggers it, then you got to get up and walk around. I lost, so I've had tight pelvic floor muscles since 7th grade. Okay, there's no doubt about that. And I have scoliosis, which tweaks the muscles. And, I was an athlete and yada, yada, yada. My muscles are tight. But I developed some pudendal neuralgia symptoms about 8, 9, 10 years ago. And at that time, I had lost a massive amount of weight. I was back to modeling because I modeled a little bit, just a little tiny bit when I was in college, just a little tiny bit. I was down to I'm 5'9", like 125 pounds, way too skinny. And I realized in hindsight, I had no fat on my butt at all. And so when I was sitting, I was just sitting on bone and muscle. And I would, and what's so frustrating as we get older is that fat doesn't always go back where you want it. Now, my fat came back to my butt. More fat came back than I needed, to be quite honest. But, sometimes it's just pure anatomy and how you're built. If you're super, super skinny and you don't have a tush, then when you sit, it can be more of an issue. Anne Marie says, my test tomorrow is a U.S. post-void residual bladder. So normally they just stick a catheter in your bladder after you pee to see if anything comes out. That's not a big test. I bet they're actually planning on doing what we call a urodynamics test. A urodynamics test is where they slowly fill your bladder with fluid. And it's all about testing how your nerves are functioning in your bladder. And so as they slowly fill your bladder with fluid, they're going to say, okay, tell me when you first feel the need to urinate. You're going, okay, I need to pee. Okay. Then they keep going. They go, okay, tell us when you first feel some discomfort. And you're like going, okay, I feel, okay, it hurts. And then they tend to push back a little. They push a little bit past that until you yell at them and say, stop what you're doing now, I'm done. Which is what I did. And it's just all about testing how your nerves are functioning. Sherry says, I just saw a retina specialist for the largest black floater in my left eye. He just wants to watch it. Yeah. Yeah, that whole age-related pieces of the retina, I forget the exact term for it, but it's very, very common. Mine was pretty big, but it's much better now. It takes about a couple of weeks to a couple of months for big floaters to go away. It does. Now, what did I do with my thingy? Is that it? Hold on here. What else do we have here that's interessante? So, Galax says, but you look 30. Good. Thank you. Thank you. I was at the gym once. Having Scandinavian ancestry is really quite nice. I had an elderly aunt who looked 50 years younger than she actually was her whole life. It was amazing. I was at the gym once and I was in the bathroom and this girl next to me started bitching about all these older women. She was looking at me like, right? I said, oh, no, I'm this age. I'm 62 now. It's crazy. Okay. So anyway, I want you to think about something for a moment. Imagine being a geek of geeks in the best possible way. Okay. In the best possible way. So imagine going to Harvard or Cornell or Yale and having a degree, a PhD in mathematics, applied mathematics. Now, that's what my brother, very close to, my brother's a nuclear physicist. That's very close to what my brother did. He got a perfect score on the SAT math portion. I did not. He did. So we have this incredibly intelligent scientist working with math who then goes to another town to do his post-grad work, has to go to Chicago to do postgraduate work. And when he gets to Chicago, he decides to ride his bicycle to work. And he's riding his bicycle over and over and over again. And then one day, urinary symptoms, pain, prostatitis. His name is Dr. Jason Kutch, and I want to show you a picture of him. He is now he's now at University of Southern California. There he is. He's a sweetie pie. One of the nicest guys I've ever met. Very humble. So he gets these inexplicable symptoms and works with doctors to try to figure out why did this happen. And the best guess is that he developed pudendal neuralgia from riding his bicycle. Okay? When you're sitting on a bicycle seat, it's pushing right up into nerves. But he developed widespread pain. So it didn't just stay in his pelvis, it went to his spinal cord, right? Central sensitization, IC subtype 5. And it affected other parts of his body. But what made him different is that he applied his scientific mind to the study of this. And he is now leading the neuroscience division for the National Institutes of Health MAP Research Network, studying how the brain and how the spinal cord play a role in chronic pain. It's just, and he's one of the first peers that I've worked with, because I consider him a peer, even though I don't have the degrees, but I think we have, we're both highly, highly qualified. And his work is nothing short of breathtaking, what he is doing. And they are now using, so I did a big interview with him in our recent magazine. Okay. And they have been mapping out sections of the brain that correlate to pelvic floor tension, right? Things like that. And they have been studying something called the salience network. And I still don't quite understand exactly what the salience network does, but it kind of, I think, establishes context, kind of, sort of. And he is the first to be able to see that patients with pelvic pain have unnaturally tight pelvic floor muscles, and that by stimulating an area of the brain, they can relax those muscles. So he has just launched a new clinical trial where he is looking for patients who would like to try neurostimulation. It's called transcranial stimulation. Transcranial magnetic stimulation, or TMS, is a way you can non-invasively stimulate the brain. It uses a device resting on the scalp to deliver brief pulses of magnetic energy which pass through the skull and modulate the activity of nerves. So my question to him was, why would transcranial stimulation of the brain reduce pelvic pain and discomfort? His answer is, we're studying how TMS might reduce chronic pelvic pain, both more bladder-centric pain as well as widespread pain. As in most studies of transcranial stimulation, we are stimulating regions of the regions that control movement, since stimulating those regions, interestingly, seems to give the greatest pain relief. We hope that our study will have a big impact on the field since we are scanning the brain before and after stimulation. We will be able to find out if transcranial stimulation is reducing pain by improving how the movement circuitry works, or if it reduces pain by indirectly activating deeper parts of the pain that reduce pain, like the periaqueductal grave area. I asked him, do you believe that a disease process is driving central sensitization and the development of widespread pain? He says, I think that central sensitization is a process by which the nervous system is interpreting the environment as threatening and storing that information to better protect itself. Why this causes pain in some individuals and others and not in others needs further research. Here's my question. What role does the salience network play in our brain? How does it change in patients with chronic overlapping pain conditions? He said the salience network is believed to be important in processing information from many sensory systems and for determining what is most important for attention. Adults with chronic overlapping pain conditions seem to have some parts of the brain that represent the body overly connected to the salience network. The implication that we need to test is whether this is causing people with chronic overlapping pain conditions to pay more attention to particular areas of their body. Fascinating. And because this is my subtype, I'm very, very interested in this. Because I would like to know why my life developed the way it developed. So I had a big injury in 7th grade, developed vulvodynia in high school, developed IBS in my early 20s, migraines in my mid-20s, sensitivities in my 20s, IC pain in my early 30s, etc. And when you're in this journey, you're like going, what the F is wrong with me? It makes no sense. I thought I was being punished, truly, honestly. I didn't think I deserved anything in life. My depression was extremely severe in my 20s, like clinging to life in my 20s, because I did not understand why my friends were out getting married and having babies, and I was laying in my freaking bathroom in the fetal position having cramps. Why, God? What the hell is this? And now we know what it is. Now we know that the central nervous system can be injured. And I certainly sustained a significant injury in my teens that he did too. And so that injury affects nerves locally, then the nerves of the spinal cord start to become involved, then the nerves of the brain starts to become involved. And we know how to turn it off. There's a very, very happy ending here. We know exactly how to turn it off with a little bit of mind-body medicine. And as he's doing, he's using transcranial magnetic stimulation of the brain to try to turn it off, right? But one of the things about pain is that it's very consuming. It's consuming. Like you can't think of anything else. It's like you're all of your attention is focused on this bladder or this tooth or that, right? And no matter what you do, your thoughts keep going back to that pain. Organ pain is relentless. It's difficult to ignore. It's a very, very challenging pain to deal with. So I asked Jason, I said, because like I'm very healed. I know that. And I absolutely know it was not my fault. But I have moments, most recently last fall, when I was diagnosed with high blood pressure, that it just consumed me for a period of time. It was like this massive amount of, it was like I was being held or crushed by stress. And that was stress from caring for my parents, right? I mean, it is what it is. And I was just really struggling to get through that moment. And I was just lost in this worry and stress about blood pressure and all this sort of stuff. And I knew, because I'd been talking to him at that time, what was going on, that my salience network in my brain was just focused here. And I needed to refocus it in another direction, because this is what we knew, is that I did all the right things. I got my blood pressure down. I'm good. I'm good. I'm fine. But it was a great lesson about how pain can change your focus and how health can change your focus. And then you're stuck there thinking about it. Kayleen, you know what I mean, right? And it's legitimate. It hurts. So I asked him, I said, okay, dude, what do you do? What do you do when you feel this coming on? What do you do to calm your entire central nervous system down? And he goes, I surf. I go surfing. As soon as I feel pain coming, I go surfing. And I was like, really? And he goes, yeah, think about it. You cannot pay attention to your pain if you're out on a surfboard. You're paying attention to the water. You're paying to the sound. Your body has no time or energy or brain cells to focus on that pain. When you are out on a surfboard, the wind is hitting you in the face. The water is hitting you in the face. It's cold. There are sounds. There are smells. All that sensory information is just wakening up. It's just wakening everything up. Galax, no, I don't. Wakening up everything else in your brain to get it functioning healthy. And he said, I can go surfing and I'll be fine for weeks. And if I start feeling it again, I just go right back and I get out on my board. I know what was so interesting is a couple of days ago, we had this monster storm come in, massive winds. It was like on Monday or Tuesday of last week. And we were expecting snow, which we don't get very often where I live. And I decided, I went out and walked in this really high wind. Like, it was so intense. I was having to push forward. I was like this. The wind was so strong. And I think I had my surfing moment. I felt nothing but this fresh air, wind, cold breeze. And I was so invigorated when I got home. I was like, oh my God, I really think I understand what he's saying there. And then I did it again. And I did it this morning. And I walk every day anyway, but walking out in the wind when, you know, your senses are just completely alive and your brain's monitoring your senses and it can't think about your freaking tooth that hurts or your bone graft that hurts, which I have right now, right? So anyway, I have an interview with him in our next issue. And I think that he's an example, like me, I think, of somebody who took something bad that happened to them and is really now trying to use it to improve science and to help other people. Emery says, now I'm a little more apprehensive. I am to drink 32 ounces before the actual procedure. So I think it may be the catheter. I don't do well with those as they tend to cause inflammation and more pain than I can tolerate. I would rather do the test you described. Well, no, I mean, no, Emery, I would do, no. You know, putting a cystoscope in your urethra is actually harder than putting a catheter in your urethra. What you need to do is be very vocal with them and say, okay, listen, I have to admit this scares me a little bit. I have a lot of discomfort whenever I've been catheterized. I need you to use a pediatric catheter. I need you to use the smallest catheter you have, a 14 or 12 French. You know, that's the diameter of catheters. They use this weird system. So pediatric catheter is like a 12 or 14. An adult catheter is like an 18 or 20. And so if you use this tiny catheter, preferably with a lot of lube on it, or a low friction catheter where it's slippery, it's a piece of cake. It's a piece of cake to use. I'm not afraid of anybody putting a pediatric catheter in my bladder. So that's much easier than having a hard metal cystoscope put into your bladder. So, and as Amy said here, I had a urodynamic study done a few weeks ago, and it's not bad at all. If you're uncomfortable, just ask them to stop. Yeah, exactly. Because in the end, you're the boss. You're the boss. It's your body. You tell them when to go. You tell them when to stop. And, we have to be assertive. We have to be very, very assertive. So Galaxat wanted to know if I have children, and the answer is no, I don't. I miscarried once, and then in my 20s, I was so consumed by IBS. I wasn't in any state. I wasn't in any state to become a parent. I wasn't. I wasn't in any state to have sex, to be quite honest. And I like sex, but damn it. It's a journey. Life is a journey. And to be perfectly honest, because of what happened to me in my childhood, it is very, very hard for me to trust a man because I was hurt by a man. Right. So I always thought I'd have 5 children. When I was in high school, I was like, you're going to have 5 kids. Absolutely. Never thought I would not have children. But then, the blank hit the fan and a lot of all these other health conditions happened and time just flew by. And then I had a hysterectomy and oh, holy hell, there you go. I cried. Oh my God. About 2 months after that hysterectomy, I just bawled my eyes out for like a couple of weeks because that's it. You're never going to have kids. Life is weird, right? David says, cystoscopy and catheter are like night and day. Dana says, absolutely. And says, thank you so much. I really appreciate you so very much. You're welcome. You're welcome. I'm not afraid to go to the doctor at all because I'm just very, I don't know. You gotta put your big girl pants on, your big boy pants on. I mean, we're going sometimes because we're desperate and we're hoping for relief, but you can't give your power away. I mean, I can remember when my 2 beloved doctors retired and then I had 2 other doctors, they just weren't as good, period. And they tried to talk down to me. And one of them was like, wouldn't give me, she wouldn't give me the estrogen that my gynecologist had ordered for me for 10 years. It was compounded estrogen. She's like, I'll lose my medical license. I went, then, well, what? She said, yeah, I just don't believe in compounding. I'm like, well, I'm a redhead. I've got really sensitive skin, central sensitization. I can't tolerate Premarin or estrates. So what do you propose? And she's like, well, you're going to have to use one of them. And I went, no, I'm not going to use one of them. Is there another doctor here that will do it? And she said, yes. And I went to the other doctor instead. I mean, there's that line you have to walk where, number one, you're going there, you're paying them for advice and information, and for treatment, ideally, but you're the decision maker here. You're the one who has to think about the pros and cons and have good discussions about pros and cons and decide what you're comfortable with, right? Mary says, I can relate. It can own you, that the pain can own you. Yeah, well, and that's really kind of a dysfunction of the salience network. And that's what Dr. Coach Jason is working on, is how to turn that off. So for anybody in Southern California, they are looking for patients to do this transcranial magnetic stimulation. I honestly, I would do it if I were down there. I would, because I can see that my brain behaves differently. And I would like, if I'm starting to have a neurologic flare, if I can nip that in the bud with a little bit of like the equivalent of a TENS unit to the portion of my brain that controls that, it'd be interesting. I certainly want to know more about it. They've already done a lot of it already. They've developed a very good safety profile, but it's very cutting edge, very, very, very cutting edge. Mary says some doctors make matters worse. Yeah, they can. They can make it worse. And some doctors are they're very aggressive. I mean, I've shared the story of a nurse with IC, and she from a small town in Appalachia. There were 3 urologists, and they all said, "We won't treat you unless you have InterStim." And she was bullied into having InterStim. She regretted it. Kimberly said, "Thank you for including me in your podcast. This is very informative, and I will." You're very welcome, Kim. You're very, very welcome. They can be condescending. I mean, and that's like, you really see that in the South, the Southeast of the US. And you see that in Europe a lot. I would say especially in Europe. But in the South, doctors are like up on a pedestal, and they want to, man, especially if you're a woman in pain, they want to pat you on the head and say, "Oh, honey, you're going to get better. Just drink some cranberry juice. Just take my antidepressant. Just take the Zelmaron. Just go on home. Relax." And it doesn't work, and you go back. "Oh, honey, come on now. You're just not trying hard enough. Are you sure this isn't? Maybe you need to have some therapy. Maybe we need to send you to therapy. Maybe you just like being in pain. Maybe you just want the attention of being in pain." Right? I mean, doctors used to say that all the time. I had a patient, an IC patient, literally, she was from South Carolina. Her father was a doctor, and she was bleeding from her bladder and from her vagina, and I think even from her rectum. She had massive blood. She was in the hospital with this very weird bleeding thing going on. And her father refused to go to the hospital to be with her because he believed that it was all in her head. And she's on the phone with me crying. "He won't even come." It's like, you're bleeding. How can that be all in your head? You're bleeding. They admitted you because you're hemorrhaging. What the F? Right? I mean, that's what we're up against. That's really what we're up against here, is we've got to change some of those old values. And we're doing that one doctor at a time. You're part of that. When you walk into the doctor's office informed, you got to be informed, you got to be educated, you got to have ask the right questions, and really show them that you're there to get better. You're not there to waste their time. You're there because you need somebody to study your body to figure out why you have pain in this certain area. Mary says, "Recently a doctor told me to learn to live with it." Well, Mary, listen, I had that happen in 1993 or 4. I went to the emergency room. I had a doctor say, "This is your life. Get used to it. You will always live with severe pain. You will always be a burden on your family." Straight out of the doctor's mouth. And I went, I was like, and I needed that moment. To be quite honest, it was a very, very important moment, because I went from being like this to being like that. What the hell? Wait a second. Wait. I got 3 college degrees. I will prove you wrong, you son of a bitch. How dare you say this to me? It's below the waist. It's not above the waist. And that was the moment when I went home and I started studying. I just started studying to learn about IC. And that's what led to becoming a support group leader and all that sort of stuff. As I went from being passive to being very, very active, it's like, oh, no. And he was wrong, because I haven't had severe bladder pain in 15 years now. Every now and then I get pelvic floor pain. But Mary says, "Say what?" Oh, no, that's the truth. Absolutely the truth. You will forever be a burden on your family. It's like, screw you, dude. I'm going to prove you wrong. And ultimately, in the end, sometimes we need those moments to actually rise above it and to take the action we need to take. Because I'm not taking that. I'm not taking that. burden on my family? Oh, hell no. No, not at all. I'm a leader in my family. Hi, PK. Hi, PK. How you doing, hon? How you doing? Let me just go take a quick peek at the folks. Hold on. I'll be right back. Hold on. All is well at the kitchen table. Thank you, Jesus. Oh, it's cold. I'm glad I walked when I did. And now we're expecting 3 more storms. And we had snow on our hills up here. But it didn't make it to my house, darn it. We had snow flurries, but nothing stuck. And I love watching snow. But it's cold. All right. Any more questions? Any more questions? Otherwise, I think we need to read another chapter. Mary says, you are a champion. Oh, thank you, Mary. PK says, where do I live? Northern California. Sonoma County, Northern California. We're north of San Francisco up in the wine country. Judy says, I sure get that. I have SIBO, so my guts have been in pain for 3 years. Yeah. You know, when I go back to my 20s and my IBS was so bad, John, here, I'll get that in a sec. I had what I call bend over and screamer cramps every morning for like 3 years, right? Straight. I mean, and these were not little cramps. These were not being able to move for an hour type cramps. And so I went to my primary care doctor back then, and they did the lookup in there. That wasn't fun. And he goes, you just need fiber. You just need to eat oatmeal. And so the OCD that I am, a little bit obsessive compulsive, believe me, I started eating oatmeal. I put oatmeal on everything. And I got worse and worse and worse and worse. And then finally, I mean, there was just no life. There was just no life. It was awful. And my sister gave me a book on allergies. And that was a book that introduced food sensitivities. A food sensitivity is not an allergy. It means that your body is, because an allergy provokes an allergenic response driven by mast cells and histamine. So a classic allergy is you get swelling, your throat closes. That's an allergenic response. A sensitivity response is different. A sensitivity response is basically that your body really just doesn't know how to process it. And so it's almost like it's interpreted kind of like poison. I mean, that's how it felt to me. That's not the correct academic description, but that's my interpretation of it. And so in this book that talked about food sensitivities, it said, okay, so first thing you do is eliminate dairy. Well, I had already eliminated dairy. I already hadn't eaten dairy for years. And then the next thing the book said is get rid of every grain but rice for 3 days. Wheat, corn, oats, get rid of everything. Dad, I'm doing a live support meeting. Okay. Well, why are you in Chrome? You're not supposed to be using Chrome, Dad.
You know,
You're not.
I'm not supposed
Okay. Well, you're not.
to. Let me tell you, there were some quite interesting sights on the
Okay. Well,
quite interesting.
you have no other Apple devices to connect to.
I know, but
So
I
okay. Well, I'm doing a live support group meeting,
okay.
so
I'll talk to you later.
you can say hi.
I get, oh, right. Very interesting.
Okay. Deep breath in. Deep breath out. One more time. Deep breath in. And a deep breath out. Okay, we're going to move on. I'm going to let that go. It's frustrating. Okay. So anyway, getting back to this whole thing. So my sister gave me a book, Terrible IBS. They're talking about food sensitivities. It said eliminate dairy. I'd already done that. Eliminate all the grains but rice. I did it. The next day I had no pain. It was shocking. It was shocking. Once I eliminated wheat, corn, and oats, the cramping stopped. It was gone. It was done. So then it's like, okay, so it's one of these three. Then they had you reintroduce it. So I reintroduced the wheat. Okay, I was fine. Then I reintroduced the corn. I was fine. Reintroduced the oats. Next day, terrible bend over and scream or cramping. And so, Judy, I believe that SIBO is real. Absolutely. I believe that I probably had some SIBO. I think a lot of us do because our diets, the modern diet pushes that. But I also really think that food sensitivities play a huge role in many of our bowel issues. And being open and receptive to the concept that there might be something in your diet on a daily basis that you think is perfectly normal that is actually the trigger. And for me, it was oats. And ironically, after I did this and I showed it to my doctor and my life was transformed literally overnight, losing the oats, I later, they had us do more in this diet. Chocolate also was a trigger. So my biggest triggers for IBS are oats and chocolate. But oats are by far the worst. And it kind of makes sense because, hello, my family's from northern Norway and Sweden. There's no oats up there. So genetically, my ancestry were never exposed to oats. So it would make sense that my body doesn't know how to process oats. And chocolate comes from Africa, and they didn't have Africa up by the Arctic. I mean, they didn't have chocolate up by the Arctic Circle. So I didn't inherit the ability to process chocolate well. And ironically, I've worked with many patients who have the same sensitivity. They can't eat oats. Mary says she took the SIBO test and it's positive. Yeah. I mean, I truly believe that our diets absolutely are terrible and certainly can cause an imbalance in our gut. But I also think that food sensitivities are worth considering because it's so nice to be pain-free. But I'll never, ever, ever eat oatmeal again. And every now and then I'm tempted. It's like, maybe you should have an oatmeal cookie and test it out. It's like, no, I don't need to. And every now and then, like once in a blue moon, once every 5 years, I'll start feeling that symptom. I'll start feeling that squeezing, cramping. And I go, all right, did I eat anything with even a tiny amount of oatmeal or chocolate in it? Every single time it was that. Karen says, where do you get a SIBO test? From your doc? They just order it? Or I think you might be able to order it online, maybe. Dana says, my dad's so sweet. Karen, you're blessed. Karen says, you're blessed to still have your parents. Oh, girl, they are work. They are work. It is so much work now. It's consuming because of all the intimate care now, and that my mom can barely walk and can barely wipe. And, it's my life is about peeing and pooping and cleaning up messes right now. Mary says her naturopath got a SIBO test for her. Yeah. Google it and see if you can order one. I have no idea. We have an old home that used to be a residential home that they're making into 3 apartments just down the street from me. And I'm actually thinking that maybe I should go rent one of those apartments and then bring in a home nurse who can be in my bedroom to provide the more intimate care, because we're quickly getting to my not I've done enemas for them. I've done all of that for them. I don't want to do that. And I can't give the medical comfort. Like my dad, he just wants to talk to a doctor like once every 4 months. And it's like, we already talked to him. Why do you want to go talk to him? I just want to talk to him. And it's like, about what? About this. But we talked about that. I want to see him. Right? So I think having a nurse here, if we could find one, a home health aide who might have a nursing background, would be good. I don't know. I'm thinking about it. I'm tired. I haven't had a night away in 6.5 years. Can you imagine? No, not a night away in 6.5 years. 7 years next fall. PK says my GI doctor said they have no SIBO test. It's not my area. Dana says that's a lot. Yeah, it is. It is. It is. And I get very frustrated because I'm not getting the help I think I deserve and need from my siblings. But my sister is legitimately sick. I mean, and COVID messed everything up, but she legitimately has health issues. But my brother's retired and lives an hour away. He could come over and help, but he won't. So I'm not going down there because I got really mad last night about it. So PK says, can we qualify for in-home? Well, no, their pensions are too good. They don't qualify for a lot of stuff. We even had a palliative doctor out, and he goes, you qualify for about an hour a month because your daughter's doing so well with you. Karen says, caregivers need respite care. Yeah, we do. Yeah, it's my dad and my mom, though. It's both of them. I've got both of them. I think that an elegant solution would be, because I don't trust convalescent hospitals at all. And I know that they deserve the best care ever, and they want to die at home. And my sister and I promised them that we would try to make that happen. But it would almost be nice if I could find a place where they could be together for those very, very last moments. I'm not making sense. It's hard. It's very hard. Amy says you deserve a break. Yeah, I do. I need a break. I have so much that I want to do. Like I need to rewrite our fact sheets. And I literally have information packets here that need updated fact sheets. And I just literally I'm lucky to get 4 to 5 hours of IC work in a day. I'm lucky. And then I have got to make dinner for them. And then after dinner, I'm fried. The stress is real. It would be nice to be able to get away for like a month and just be Loretta says, Dr. Mark Pimentel is the authority on IBS or SIBO. Are you familiar with him? Amazing. SIBO tests are not easy to get at home unless you have a doctor sign off and have one to interpret. Easier said than done. Check out the SIBO SOS community. Amy says, you can come here to visit in San Diego. I spent a lot of time in San Diego because my aunt used to live there. My cousin lives there, and I love my cousin dearly. And I have a plane flight that leaves Santa Rosa and arrives at San Diego, which I've taken several times. But if I won the lotto, I mean, like, seriously, where would you live if you won the lotto? And for me, because I have a very small life right now, right? Because of what I've, because of my own old health issues, but also doing what I've been doing for the last 15 years with my parents. Like, where would I want to go? And, Amy, where I would go? I would love to stay on Coronado. So I do my Zillow porn. We call it Zillow porn. For all of us who've been through fires and we've become close to very fires, losing our homes in fires, we spend a lot of time looking at Zillow at home listing. So we call it Zillow porn. So I do my Zillow almost every night, and I just relax and I just look at homes and, like, where would I be? I could go there. I could go there. I could go there. I go back to. I know Amy goes big bucks. I know. Well, this is if you win the lotto. But then I think, catastrophic thinking, I go, well, what about the tsunami? Maybe I need to be up on a hill. So not on Coronado, maybe up on the hill. But anyway, I often think about San Diego because I have very, very good memories of San Diego. Latasha says, get some help. You need breast. I do. PK says, there's home care for mom. I think you can research it. Yeah. It's just my mother is scared of people coming into the home. She's scared. She doesn't want home visits. But Weston Marco says, I cannot imagine what you have to go through. Your hero. Oh, thank you. Wanting One Angel said, oatmeal never really bothered my bladder. As for nursing homes, my father had Alzheimer's and he was abused in a nursing home. I'm not saying all nursing homes are abusive, but some of them can be so. Exactly. Loretta says, Dr. Pimentel is at Cedars-Sinai. These conditions interact in such a profound way with IC. Agreed. I should try to. Loretta, can you email me? Could you email me icnetwork@mac.com a little bit about him? Because maybe I should interview him for our magazine and for our website. I should do that. Amy says she's about 35 minutes north of there. Yeah, so is my cousin. And I look at all those communities. John says, which spice? Oh, John, I'm sorry, hon. Which spices are safe to eat? Italian spices. So you can do the oregano, you can do the thyme, you can do the rosemary, you can do garlic powder. It's the things like sriracha that would be potentially more irritating, or hot chili pepper flakes. I would pass on those. Karen says, can you hire someone from a local college to help you with the IC responsibilities? Well, I have employees. We have 4 total employees, and I'm one of them. But I could, and I've thought about this. I really could give Stacy become the content leader for the IC Network website and for us. It's just I enjoy it so much. I love writing articles. I'm trying. We're thinking about it. Mary says she would live in Carmel. Oh, girl, I have looked at Carmel. I love Carmel. I like it a little bit warmer. Where I think would be a perfect place to live would be up by Solvang, in that valley just north of Santa Barbara, over the mountains from Santa Barbara, where Olivia Newton-John lived. That looks really cool. But that's also very expensive. That's a wine area also. You know, that you kind of think, okay, I'm going to get away from any place there can be a fire. So you go down to the coast. And then the coast is cold. So you want to come back where it's warm, but then you got to deal with the fires. Weston Marco says, I eat oatmeal 3 days a week. Should I avoid that? No, not at all. If you're not having any symptoms from the oatmeal, we brought up oatmeal because we're talking about IBS and food sensitivities. And some of us had food sensitivities that can trigger symptoms, and not only bowel symptoms, but even bladder symptoms. If you flare during allergy season, I mean, that's a distinct subtype in Dr. Nichols' 9-point subtyping system that he proposed a couple months ago. Allergenic IC BPS. That's it. So he's the first one to create a subtype for this group of patients. And so if you're in this group, then we have to pay attention to the things that you're allergic to and maybe avoid those, whether it's food, whether it's if you have environmental allergies, hay fever. We've had a lot of hay fever here with the acacia trees blooming. That can certainly irritate everything. And so these are the patients who would benefit the most from antihistamines, according to his system. PK says, I think I have IBD. But I just am very sensitive to oatmeal. I can remember as a kid making oatmeal cookies and getting sick when I was like 13 or 14. So it's just one of the foods I don't like. I got to say, John, hold on a sec. Hold on a sec. Hold on. The parents are yelling at each other. Hold on. I'll be right back. That's the last one. Okay, I'm doing my support group meeting. It sounds like they're fighting, but they're not. They're both hard of hearing, and they end up yelling at each other. My mother wanted root beer on ice. He couldn't hear her. Okay. Anyway, John, I got to say, have you ever heard of Penzies? Penzies. Penzies is a spice company, and we have and they're nationwide. And my niece sent me 3 different ones for Christmas. So I got baking spice, which is fabulous for baking. I haven't used this one yet. It's called Sunny Paris. It's like for cooking with chicken. And this has shallots, chives, green pepper, French basil, tarragon, chervil, bay leaf. I love bay leaf. Ooh. Oh my God, that smells good. But it smells salty. Is there salt in it? No, there's no salt in it. But this one's been the mind blower, and that is original taco seasoning. And like I always stayed away from this. It's got paprika, salt, onions, corn flour, little bit of tomato powder, a little bit of cumin, garlic, oregano. Oh, look at that. It's even got cocoa powder in it. Wow. Well, that's interesting. Anyway, oh my, it smells so good. I've actually used it a couple of times. Not a lot. I mean, they might say like they say, sprinkle 4 tablespoons of taco seasoning over beef. I would do a half a teaspoon, which I've done, and I haven't had any issues with this. So anyway, Penzi spices might be interesting. Loretta says, my brother and I went through this with both parents. We were ready for respite care before they passed. No one knows what caregivers go through. I just admire your dedication. Many of us know how stressed you are since we have walked in those shoes. You must take care of yourself. Yeah, thank you. Thank you. I definitely have moments when I feel my blood pressure rising, like last night, which is why I got up this morning and did a long walk and took my blood pressure medicine. I don't have any thoughts on the FODMAP diet, to be quite honest. Wes and Marco says, I have Hunters. What is the best supplement like Bladder Builder? I'm now searching, but there are so many choices out there. Well, since Hunner's lesions are either driven by virus or driven by nerve inflammation, we kind of have to distinguish between the two. If, for example, you think it's viral in nature and you have a viral test that confirms that you've got polyoma or HPV or something like that, I would be thinking about things that contain lysine, because lysine interferes with viral replication. In contrast, if it seems like it's coming from nerves that are very, very inflamed, I would probably be looking at things that contain PEA, palmitoyl ethanolamide. But there's no supplement that has been developed and designed for Hunner's lesions, because we still have questions about Hunner's lesions, but the viral connection is becoming all the more important. So I don't see a chondroitin-based supplement being particularly helpful for a Hunner's lesion. I think something that is so calming and soothing that can calm nerves down make a little bit more sense. So Allopath, I was working with a patient like 2 weeks ago who was using Allopath, a combination of aloe with PEA for her flares, and was doing very well on it. So in the end, it's about trying to figure out what will work the best for you, and trial and error. And we all have to be very, very careful, because there's no supplement other than Pre-Leaf which can make any claims about treating interstitial cystitis. And Pre-Leaf is classified as a medical food for IC, and they met specific criteria that the FDA gave them. So we have to be very careful about the statements that we make. And I'm the first to say, I mean, listen, I'm the first to say that we have to understand cause versus effect. I don't believe in taking a lot of anything. I think it's very important to stop what you're doing, take a step back, revisit the diagnosis, and let's see if we can figure out what's driving these symptoms in the first place. And for those of you who have taken bladder therapies for years and you're still flaring, who is it? I was working with somebody who, oh God, this was really mind-blowing. Okay, so literally, okay, what was she doing? Every 2 weeks, she did a home DMSO treatment. And she had to do it every 2 weeks. If she pushed it out to 3 weeks, her symptoms came back. And she had done this for years and years and years. Loretta, just as basic info. That's all. And so this is a perfect example of somebody who is chasing their symptoms. And I said, but so she wanted to know what she could add to that. And I did not cooperate. I said, oh, Amy, was that you? So, I wasn't particularly cooperative, right? It's like, okay, before we go there, let's look at cause versus effect. Because if you had to do it every 2 weeks, it wasn't fixing anything, right? I talk to so many people, it's hard for me to keep them connected. And so, as our AUA guidelines say, is if you're not responding to therapy and you're getting worse rather than better, then we don't want you to keep doing the same treatment over and over again. We want to find the right treatment that will work, right? That will actually heal tissue so you won't have to keep doing it. And Amy says, yeah, it worked for 14 years. Right. But now, Amy, refresh my memory if I'm wrong or not. Don't you also have really, really, really tight muscles? Yeah, we just always have to look beyond. I don't want to settle. We don't want to settle. Oh, bad back. Okay. Right. Life is I understand that. Who wouldn't want to feel better? You're absolutely doing something that kept you functional, kept you operating, made you feel better. And there's anybody who doesn't understand that need and that motivation, because we want to keep working, we want to keep supporting our family and all that sort of stuff. But what we've learned is that monotherapy does not get a patient better. And so now you're doing rescue installations every few days, bupivacaine, heparin, and solucortef. Okay. And it's hard when you've got a bad back. You and Kayleen should connect. Kayleen's struggling with the same thing. She's got some pretty challenging back issues going on. Just to sleep? Yeah. And like, to me, for my care, I always want to understand the physiology. I always want to understand the anatomy. Why does it hurt the way it hurts? What is the underlying issue? Is it estrogen atrophy? Is it a traumatic injury, etc.? Sandy, the spices came from Penzies. I know on YouTube, you guys, everything's backwards, but it's P as in Paul, E, N as in Nancy, Z as in zebra, EYS, Penzies. I gotta say, this taco seasoning has a great flavor, but I would never do 4 tablespoons. It's like, a teaspoon at the most, half a teaspoon more likely. So Amy, your case is really, really interesting. Your case is fascinating to me, because I want to know why your bladder wall isn't healing over time, because it was not healing. Hey, Sue. Nice to see you, girl. Hope you're well. Hope you're feeling well. I just think that, when you're in the middle of it, you're just desperate and you're willing to grab onto anything to do. And that's where we have to be very it's very hard to be proactive when you're in pain. It's very hard. You call your doctor and you say you need help, give me help, and you'll do the first thing they say. And yikes. Sometimes we have to go, okay, can you help me understand it first? And then let's talk about my treatment options. So help me understand the anatomy first. Is my skin hurt? Is my skin dry? Is my skin damaged? Do I have a nerve issue? Help me understand the anatomy. And then based upon that, then let's talk about what might be the best therapy for me, right? Sue says, doing much better, thank you. Starting back physical therapy next week. Something. Good, good. I'm glad you're going back, Sue. It's going to be very interesting to see how that scar tissue responds. Amy said, an E-string for a month. Yeah, you had an E-string for a month? E-string is another way of getting estrogen into your vagina. It's actually like a little round donut that releases estrogen on a time release factor. I personally tried it. I didn't like it. It kept falling out for me. I like the cream. I can do a lot with the cream. But the E-string was just I thought it was kind of strange. For 3 months, interesting. I think the challenge is for some of us, like I could never use a tampon comfortably, like never. And I have such nerve sensitivity down there, and I have a lot of rectal sensitivity. I mean, and there's nothing wrong with my rectum other than, the occasional hemorrhoid. It's just the nerves are very sensitive in that whole area from my injury. And so I can feel anything that's in my vagina, and I can feel anything that's in my rectum, and it annoys the hell out of me. You're welcome, Sandy. Sue said, my mother, since having a hysterectomy, cancer, chemo, and radiation, is popping oxys like candy. Burning, I keep telling her to talk to her doctor. What kind of doctor should I ask her to go to? She could not make it to Beaumont. A gynecologist, hon. So if she's having, so she had a hysterectomy from cancer, chemo, and radiation. So the chemotherapy would have chemically damaged her bladder wall. The radiation would have damaged blood vessels and potentially nerves. So that's a real pickle. So I would understand why she would be, no, she's doing pyridium every day. Is she drinking coffee? I mean, listen, she's had a hysterectomy. She's much older. She's completely dry down there. And she's probably not using any topical estrogen because of the history of cancer, even though the research says she's afraid to use the estrogen cream because of cancer. So that's a case where she has to be absolutely perfect with her diet. Perfect. She's not going to tolerate a multivitamin, green tea, black tea, soda, anything at all like that with a very, very dry bladder wall. And I would encourage you to, let me see if I can find it. Hold on. Let me see if I can find one of the new studies. Because there was a very important study. Is this it? Hormone replacement therapy in cancer survivors, a review of the literature. Oh, I think you're just going to need to go. Let's see. This is one place that you can start, but this is 2020, and I think that there was a big research study released last year. She's 3 years out, no cancer came back. What kind of cancer was it? Was it ovarian, uterine, cervical? What kind of cancer was it? Sue says she just talked to her about her diet today and how important it was and to go to a doctor. So Sue, so it's uterine cancer and it spread to some lymph nodes. Okay. So Sue, the best way to explain this is to talk about dryness. So tell her, again, do what I say. Think about your bladder for a moment. It's the only organ in the human body designed to hold toxic waste because urine is body waste. Urine contains ammonia and urea and other irritants. So how can the bladder hold ammonia for hours at a time and not get damaged? Well, it's because your bladder has a really thick, robust coating of mucus. And that mucus, so your bladder is like your mouth. It's a hollow organ that's wet on the inside. And that mucus acts as a barrier. It's protective to the skin. So it's that really thick coating of mucus that allows you to drink that coffee and not suffer irritation from that coffee. But unfortunately, that mucus is estrogen dependent. So when you're young and have lots of estrogen, then you got lots of mucus. But once you've had hysterectomy and once you're of a certain age, you don't have the estrogen anymore, which means you don't have the mucus so much anymore. Therefore, your bladder's ability to defend itself is now compromised. It doesn't have the coating it needs to protect itself from her coffee. Oh my God, she's drinking coffee and eating grapefruit? Yeah, and she's miserable and stubborn. Well, I'd be happy to talk to her, Sue. I'm pretty good at explaining the anatomy and convincing somebody why it would be reasonable. If you could at least get her to start drinking the Dandy Blend herbal coffee, that would be great. But that grapefruit is devastating. That citric acid from that grapefruit. Ask her, you can say to her, say, you know how painful it is to have a dry mouth? When you have dry mouth, it's hard to talk. You always want to be drinking water. Well, how do you think dry bladder feels? Well, dry bladder hurts too. And if you have a physically dry bladder, then it can't protect itself from that coffee and that grapefruit. And that's why those nerves are screaming. That's why she's in so much pain. And she's physically preventing healing. That every time you drink that cup of coffee, you destroy the next generation of cells. So every cup of coffee sets you back 2 weeks worth of tissue growth. Sue says, I'm going to go over there and see if I can make a phone call and hook up with you while she's there because she's very stubborn and won't listen to me and she shouldn't be taking pain meds either at her age. Well, I disagree with that at that part. I think it's very important that she not suffer, but this is a preventable pain. Do you want to do this today? What am I going to do after this? Normally I go and walk. Well, the sun is starting to come out. I might try to go walk. My point being is that she doesn't need to if she would just listen. Yeah. John says certain foods will burn and irritate the inside of my mouth and can even cause a contact-like burn that will cause a thin layer of skin to come off. I'm assuming there's a connection between that and my bladder. I don't know, John. I will tell you, I have that happen with walnuts. If I eat walnuts, they burn the inside, they irritate and burn the inside of my mouth. I can't say I've ever made a correlation between walnuts and my bladder, but I don't like them. All right, what was that beep? Something just beeped. All right. Weird. Yeah. So Sue, this week, if you want to try to do that this week, that'd be fine with me. Um, Tomorrow I'm going to be putting our magazine to bed, so to speak. So I'll be doing my Tuesday. I've got just a regular work day. I'm open Thursday and Friday. And I read it. Yeah. Okay. Now we have our book, IC 101. It's not just a bladder disease. This is the top book right now, because it's a first book to talk about phenotyping and etc. Diane says, I'm feeling overwhelmed trying to figure out the best diet because I've got IC, IBS, SIBO, so many times just drinking water and fasting to see if I get relief. It gives me so much anxiety. Diane, I hear your pain, honey. I've been there. And luckily, the IC and the IBS diet really correlate very, very well together, except with the IBS diet, they tell you to do citrus, but with the IC diet, no. It's really just about eating simple, fresh, healthy food, right? And finding those foods. Like I'm getting very simple with my diet now. I mean, I love one pot meals, homemade one pot meals that'll last for 2 nights, but I don't like fancy food at all. There's this cute kid on TikTok, and I'm not looking at TikTok right now, but a toddler that the parent was giving them lots of different foods and really fresh, simple foods, whether it be, a grape or a piece of avocado or a piece of chicken or whatever. And it was fascinating to see what this toddler gravitated to. Like they tried to give the toddler ice cream, and she didn't want ice cream. She wanted something else. It was fascinating. So finding those simple. I've got radishes in my refrigerator right now, and I'm going to have a couple for dinner. And we had artichokes last night. Always good artichokes. All right. So the next chapter I'm going to read is our chapter on treatments. Let me get a drink of water. Okay, chapter 3, treatments. The AUA guidelines for IC-BPS. Now realize these are the guidelines before the update because the book was written 2 years ago. So I have to rewrite this section, but it's still relevant. In 2011, prior to the use of phenotyping, the American Urology Association released their first treatment guidelines for IC-BPS that are still relevant today, especially for patients with bladder wall-driven symptoms. Arranged in 6 steps, they suggest starting with easier and less invasive treatments with fewer side effects before progressing to more invasive, risky methods. This does not imply that a patient with severe symptoms should wait for the most effective treatment. Instead, the initial level of treatment must depend on the severity of the symptoms, as well as the doctor's judgment and, rightfully, a patient's preference. The AUA suggests that urologists practice multimodal therapy using multiple treatments simultaneously and encourage physicians to stop therapies that are not providing relief. Okay, step 1, self-help. Step 1, focus on foundation for healing. Number 1, learn as much as possible about IC. Number 2, increase your water intake to increase urine, to keep urine dilute. Number 3, follow the diet recommendations. Number 4, use hot and cold therapy. Number 5, stress reduction. Number 6, muscle relaxation. Number 7, meditation, guided imagery, avoid known triggers. And the AUA says try over-the-counter supplements. Amy says, I miss Mexican Chinese food. Honey, I have those all the time. You don't need to miss Mexican food. Mexican food's very low acid. Refried beans are great. Tacos are great. You just got to be careful of the tomato and the spices. All right. Patients who struggle with acid irritation may benefit from an acid-reducing product, such as Preleaf. Patients seeking a bladder coating effect due to estrogen atrophy or general bladder irritation should look for supplements that contain chondroitin, including Bladder Builder, Bladder Rest, Cysto Protect, Cysto Renew, and Cysto Mend. Other supplements may have a calming and soothing effect, like Allopath, Desert Harvest Aloe, bladder ease, or bladder Q. Every supplement has the potential to trigger side effects, usually in the stomach or bowel. So start slow with just one pill to see if you tolerate it well. Increase the dose gradually to the manufacturer's recommended dose. Please note that many patients prefer to take low doses, perhaps even just one a day. Step 2, oral medications, bladder installations and physical therapy. Oral medications, antidepressants. Some patients are surprised and or offended when their physician suggests using an antidepressant to help with their IC symptoms. When provided in low doses, antidepressants can help calm the nervous system and are a standard treatment for chronic pain. There are several types of antidepressants, including tricyclic antidepressants, selective serotonin reuptake inhibitors, serotonin and norepinephrine reuptake inhibitors, noradrenaline reuptake inhibitors, and monoamine oxidase inhibitors. Oh, this is going to be hard with my throat today. Amitriptyline is the most common oral tricyclic antidepressant suggested to IC patients. Many patients have benefited from its analgesic, antihistaminic, and sedative effects. This medication is taken at bedtime when it helps to combat nocturia. Amitriptyline can have a temporary stimulating effect before a sedating one, and the drowsy effects can sometimes last through the next morning if taken too late at night before. Side effects include dry mouth, constipation, dry skin, sun sensitivity, weight gain, sweating, tachycardia, and decreased blood pressure. Other tricyclics include Sinequan, Pamelor, and Tofranil. Cognitive decline, dementia, Atarax, hydroxychloride, and Vistaril, hydroxyzine pamoate, blocker antihistamines, and mild anti-anxiety medications. Hydroxyzine is used to block mast cell secretion, swelling, and inflammation. Most patients begin with a small dosage at bedtime. Patients may notice an improvement in a few weeks or months. Hydroxyzine may also help patients with allergies, migraines, and IBS. Side effects include dry mouth, drowsiness, and weight gain. A liquid form can be prescribed for patients sensitive to fillers and or dyes found in capsules and pills. And because of hydroxyzine's sedating effect, best taken at night. Patients who are allergic to acacia should avoid Atarax and possibly generic hydroxyzine hydrochloride. Okay, bladder coatings. Elmeron, pentosan polysulfate, was the first FDA-approved oral treatment developed for IC BPS. A heparin binding compound acts to fill the gaps or wounds in the bladder's gag layer. Elmeron is sometimes recommended to IC patients undergoing chemotherapy to help protect the bladder wall from the irritating effects of the cancer meds. It is also known to have anti-inflammatory properties that decrease the oversensitization in the bladder, resulting in less frequency and pain. Some scientists suggest that this medication may act as an inhibitor of growth factors and free radicals and may possibly provide a barrier against bladder infections. Common side effects include diarrhea, nausea, which is thought to be caused by the capsule, headache, hair loss, rash, and easy bruising. Patients are encouraged to stop the medication 3 months before surgery due to its blood thinning effect. Stomach upset is common and can be avoided by pouring the medication out of the capsule and into water. In 2018, a devastating new side effect was discovered affecting the eyes. A new retinal disease, pigmentary retinopathy, has been documented in multiple research studies of patients using Elmeron. 2 clinical studies found that approximately 20% of patients using Elmeron showed changes in their retinas, and tragically, the damage appears to progress even after the medication is stopped. Drug cessation is strongly recommended in any patient reporting eye symptoms. If you have used or are currently using Elmeron and experiencing vision loss, difficulty reading, difficulty seeing in lower light, or blind spots, please request a retinal examination. You can learn more about this at pentosaneYedisease.org. Elmeron has been used in bladder installations with modest success. Another barrier to its use is cost. No generic medication is available in the USA, though it is available in Canada and Europe. Okay, bladder installations. Bladder installations via catheter are usually performed in the doctor's office. Prior to the installation, a urine specimen is collected to rule out UTI. Most doctors prefer to use a small pediatric catheter for IC patients because it is narrower. However, there are patients who prefer a larger adult catheter because it allows the medication to enter the bladder more quickly. Hydrophilic catheters are generally preferred because they have a slippery surface that makes it easier to slide in and out of the urethra. Female patients should avoid stirrups when holding bladder installations. Maintaining the position in stirrups for 15 minutes or more can result in low back and hip pain. Instead, the exam table should be extended to support bent knees and flat feet if the patient chooses to lie down. Sitting on the end of the table also presents a problem. Many gynecological tables have a slight tilt for examination purposes. Sitting on this tilt causes the pelvis to roll into a posterior position, which can also lead to low back and hip pain. It's best to sit in a chair or on the side of a table while waiting for the doctor or nurse. Heparin. Heparin sodium is a medication that mimics the bladder's gag layer because it has chemical similarities to chondroitin and glucosamine. Heparin installations coat the bladder and calm inflammation. Urologists often use heparin alone or mixed into a bladder cocktail. Doctors have different opinions and often customize formulas that they use for heparin installations. Anesthetic installations. Lidocaine installations, also known as a rescue installation, are used for their anesthetic effect to calm nerves, for their ability to increase bladder capacity, urine flow, and the length of time between voids. Lidocaine is often mixed with other medications, such as sodium bicarbonate, a steroid, and a bladder coating, heparin or Elmeron, and sometimes an antibiotic. The bicarbonate improves the absorption. Marcaine is a longer-acting anesthetic that can be used, particularly in patients sensitive to lidocaine. When a patient has a bad reaction to a cocktail, the doctor may not know which ingredient has irritated the bladder. A patient can ask to restart with just one or two ingredients to detect which, if any, of the ingredients are irritating. Okay, chondroitin or hyaluronate. Uracil, which is chondroitin sulfate, is a glycosaminoglycan gag layer which temporarily coats the bladder lining. It is approved for use in Canada and Europe, but not in the USA. Cystistat, also known as hyaluronic acid, also acts to coat the bladder wall and again is not available in the USA. Ialuryl, which is chondroitin and hyaluronate, performs better than the individual coatings above, but it too is not available in the USA. All right, DMSO. DMSO, also known as Rimso 50, was the first and only bladder installation approved for IC in the USA. It has analgesic, antihistamine, and muscle relaxant effects when used in low doses. DMSO installations have fallen out of favor because they can trigger intense discomfort and an unusual garlic aroma. And that's very true. One study found that the FDA-approved dosage of 50% caused intense, potentially irreversible bladder spasms. Therefore, it is usually mixed with other medications to reduce the dosage to about 25%. DMSO cocktails may also include hydrocortisone, lidocaine, marcaine, or heparin. Once instilled into the bladder, patients are instructed to hold the med for 15 to 20 minutes before urination. Patients generally go through a series of 6 or 8 installations, one per week, before they assess to determine if it is helping them. And we have a consumer alert here. Some pharmacies have mistakenly purchased industrial-grade DMSO, which can result in severe bladder damage. Always make sure that the DMSO being used is the brand name Rimso 50. Patients are also recommended to have periodic ophthalmologic slit lamp examinations, blood counts, kidney and liver function tests a few times a year. Amy says, yes, very bad breath for 24 hours. Physical therapy. The effectiveness of pelvic floor physical therapy for the treatment of IC was validated with the release of a large MAP research network study in 2009, which found it remarkably successful at reducing symptoms of frequency, urgency, pressure, pain. Generally, the urologist or gynecologist makes a referral to a physical therapist trained in pelvic floor work. If the doctor doesn't have a direct referral, patients can contact the American Physical Therapy Association, the International Organization of Physiotherapists, or the International Pelvic Pain Society for a list of therapists. We have a great website, pelvicrehab.com, where you can go find them too. Pelvic pain patients usually present with extremely tight, quote, high tone, end quote, pelvic floor muscles, as well as tension in the legs, lower back, core, and hips. The focus of therapy must be aimed first at relaxing the muscles, and then, if necessary, strengthening them. Kegel exercises are not recommended and are usually painful. The physical therapist will perform both an external and internal therapy using firm, smooth, and blending finger strokes that encourage muscle relaxation and trigger point release. Some electrical stimulation modalities, such as cold laser light therapy or therapeutic ultrasound, can be applied externally to the lower abdomen, pelvic floor, hips, sacrum, and lower abdomen. Vaginal and/or anal probes used in electrical stimulation are not as effective and increase pain in some patients. Physical therapy isn't limited to the pelvic floor. Ideally, the whole body should be evaluated to determine if there are mechanical abnormalities influencing the pelvic floor muscles, such as bad hips, SI dysfunction, knee, leg, or foot dysfunction. A good physical therapist will also examine the adductors, which are the inner thighs, gluteus, your buttocks, piriformis, your hip rotator, your hamstrings, your quadriceps, iliopsoas, hip flexors, quadratus, rectus abdominis, external obliques, and other muscles. Internal therapy should only be used when patients are ready. Patients who cannot tolerate manual therapy often get relief from soft tissue release externally. Most importantly, the physical therapist should be teaching the patient how to recognize when tension first begins and how to treat it at home. In some cases, the glass wand is used with great success. Okay, step 3, hydrodistension and Hunner's lesion treatment. Step 3 treatments are significantly more invasive and require an outpatient procedure in a hospital. Hydrodistension not only allows a urologist to examine the bladder wall, it can also provide short-term symptom relief. About 1/3 of BPS patients report that their symptoms improve. Why? Because when stretched, the sensory nerve fibers in the bladder wall are broken and bladder capacity is increased. Unfortunately, the nerves do grow back and sometimes in greater quantity. Thus, this is rarely repeated in patients. The American Urology Association encourages the use of low-pressure, short-duration procedures to reduce the risk of bladder rupture. Now, Hunner's lesion treatment. Hunner's lesions do not generally respond to traditional oral medications and or bladder installations. They require more aggressive lesion-specific therapy. They can be treated in 5 ways. Number 1, triamcinolone injection into the center of the lesion is preferred because it does not cause scarring of the bladder wall. Triamcinolone, a corticosteroid, has a 70% improvement rate with Hunner's lesions. Fulguration, cauterization, uses heat to burn away the Hunner's lesion. Fulguration may lead to scarring of the bladder wall over time, possibly decreasing bladder capacity. Number 3, laser therapy can be used to destroy the nerves in the lesion and to decrease the substances that promote inflammation. It will also cause some scarring of the bladder wall. Number 4, Lyris is a medical device inserted into the bladder where it releases lidocaine continuously over a 2-week period. Several research studies reported that lesions healed, reduced in size and number with treatment, but much to the regret of patients, research to gain FDA approval has been halted. And last but not least, hyperbaric oxygen therapy may help improve blood flow and healing to the bladder. Okay, step 4, neuromodulation. Step 4 therapies significantly increase the risk of potential side effects. Botox, when used in the bladder, may help silence dysfunctional nerves, but can also cause long-term urinary retention, requiring catheterization. Neuromodulation, when performed surgically, has thousands of serious adverse events reported to the FDA MOD database, including fatalities. Each of these treatments requires some research and a thorough discussion with your clinician about the risks and benefits. Botulinum toxin A, Botox, can be injected into the bladder wall to stop contractions of the muscle and the release of sensory transmitters that promote abnormal pain sensations. It can also be injected into tight pelvic floor muscles and trigger points. Botox is not considered a standard treatment for IC-BPS. A patient must go under anesthesia for treatment and may need to self-catheterize for a long period of time if the nerves that control urination are accidentally silenced. And Botox is not recommended for patients who cannot self-catheterize, such as the elderly. Neuromodulation. Neuromodulation uses a mild electrical impulse on various nerves, sacral, pudendal, and tibial, involved with bladder function. Stimulation appears to decrease frequency, increase bladder capacity and blood flow to the bladder, increase urinary concentrations of heparin-binding epidermal growth factor like growth factors, and reduce concentrations of the anti-proliferative factor, a urinary marker associated with IC. Neuromodulation has been found to be particularly helpful for patients with pudendal nerve entrapment. Urgent PC, post-tibial nerve stimulation, is the least invasive form of neuromodulation and requires no surgery. It targets the tibial nerve just above the ankle. Known as urgent PC, it is approved for overactive bladder and is often used for IC BPS. During a 30-minute treatment, the doctor or physical therapist inserts a fine acupuncture needle near the tibial nerve above the ankle at the SP6 acupuncture point. Needle insertion is usually painless. The needle is then connected to a battery-powered stimulator, which sends impulses to the tibial nerve and sacral area that controls bladder function. The technician will slowly increase the stimulation while looking for characteristic signs that the correct nerve is being stimulated, usually the big toe flexing downward or the little toe splaying outwards. Stimulation should not be set so high that it causes pain. It should always be reduced until no pain is experienced. If it hurts, nerves may be damaged. The stimulation is maintained for 30 minutes. Longer periods of stimulation are not recommended, and the standard number of treatments is 12. If successful at reducing symptoms, patients can return as needed. Side effects are minimal, minor discomfort or bleeding at the needle site. Patients need a good backup support during treatments, which requires patients to sit and rest the treated leg on a block or a chair. If the hip or low back pain occurs, a standard-sized towel can be folded in half and placed under the buttock of the lifted leg. This is an Aston pattern modification technique. Okay, InterStim. InterStim is an implantable device typically used to treat urinary urgent continence and overactive bladder. It may help some IC patients with urgency frequency, but is not recommended nor approved for pelvic pain control. The InterStim trial involves placing an electrode surgically at the designated nerve and then connecting it to an external impulse generator. The patient has control over the device and can turn it on or off, as well as increase or decrease the intensity of the stimulation. If the patient experiences improvement with the trial, they are eligible for a full implantation of the generator. Although rare, there are patients who experience greater relief with bilateral stimulation, which requires 2 devices, 1 in each buttock. Some patients benefit from a single bilateral device, which works like having 2 implants. There are many possible side effects, including abdominal pain, lead migration, possible sensitivity to the implant, deep tissue MRSA infection. Patients are advised to avoid activities that put them at risk for a high-impact fall, which could cause damage to the device or dislocate the lead wire. Fixing the damage to the device usually requires surgery to replace or reposition the wire or device. The InterStim device is sealed with silicone rubber. Medtronic offers a test to detect a patient's reaction to the InterStim device. If a patient cannot tolerate the device, it can be changed to accommodate the patient. Patients should always confirm that the device and surgery is covered by their health insurance. Get an approval in writing from both the physician and the insurance company. Some patients have learned after the fact that their surgery was not covered, despite being assured that it was, and received bills of over $50,000. InterStim requires constant monitoring. The devices may require quarterly checkups to ensure that they are operating properly, especially if unusual symptoms develop, such as pain, shocking, or a burning sensation. Patients are usually advised to remove devices that are malfunctioning or ineffective because they might limit their ability to have future testing done for other medical conditions or emergencies, such as an MRI. The longer they are implanted, the harder the removal becomes due to the development of scar tissue, especially around the leads. The new InterStim microsystem features a rechargeable battery and is approved for MRI testing. All right, step 5, cyclosporin. Some clinicians are excited about the results that they've seen in patients using cyclosporin, particularly patients struggling with inflammation and or Hunner's lesions. Cyclosporin is an immunosuppressant peptide that is produced by an extract of soil fungi. Cyclosporin inhibits lymphocytes, white blood cells that are responsible for immune responses, by suppressing the immune system. It is typically used for organ transplant, but has been shown good results in the treatment of severe IC, as well as several autoimmune disorders, including psoriasis. Cyclosporin is placed in step 5 because of the risk of more serious side effects, including immunosuppression, high blood pressure, kidney damage, tremor, excessive hair growth, pancreatitis, liver damage, and more. Urologists will rarely prescribe this medication. Patients are usually referred to an immune specialist for treatment and consistent monitoring. Step 6, surgery. Surgery is the last resort for patients and reserved for the most severe cases of IC and only after all other therapies have been attempted. Some patients have mistakenly assumed that their bladder removal would eliminate their symptoms, only to discover that their pain continued. Why? Because pelvic floor muscles, nerves, and other structures in the pelvis can also be the source of pain. Most bladder surgeries have extensive recovery periods and substantial risks. Postoperative pain can be intense. Post-surgical chronic infections are somewhat common. Incontinence is also possible. Prior to surgery, it is important to talk with the health insurance company to determine what they will cover in terms of supplies. Some patients are stunned to discover that they were only given a few bags or catheters a day to use when they needed many, many more. Augmentation and bladder augmentation surgery. The bladder is made larger by adding a section of the patient's bowel. Only the scarred, ulcerated, and inflamed sections of the bladder are removed, leaving the healthy tissue in the base of the bladder intact. The patient may be able to void normally with the bladder substitution after the incisions are healed. In patients with small and contracted bladders, the symptoms of pain, frequency, urgency may continue or return after surgery. In some instances, the new tissue made from this section of the bowel may become diseased. Patients may also be at risk for incontinence, or the opposite, the inability to void at all. When this is a result of surgery, the patient must use a catheter to empty urine from his or her bladder. And cystectomy and urinary diversion. Bladder removal, cystectomy, may be required in cases where the bladder becomes severely scarred, stiff, or unable to expand to hold urine. And guys, this is really, really, really rare. After the bladder is removed, a urostomy is performed, which allows urine to be rerouted via ureters to an internal pouch made from a small portion of a bowel or a stoma, where it can be collected in a bag. If your doctor is suggesting surgery, ask to talk with other patients who have gone through this so that you can learn about the pros and cons and challenges that they've experienced. The Interstitial Cystitis Network Support Forum has a message board dedicated to bladder removal patients, and we do. Okay, treatment's no longer recommended. Long-term antibiotics, Bacillus calmette-guerin, high-pressure, long-duration hydrodistensions, long-term steroids, urethral dilation, and urethrotomy. Older bladder installations, chlorpactin, silver nitrate, and ricinoferritoxin, are no longer recommended, nor are they even mentioned by the AUA as treatments for IC. So what are your other treatment options? Well, allergy and asthma meds. It's not unusual for patients who struggle with allergies to notice that their symptoms flare during allergy season. A variety of allergy, asthma, and antihistamine medications have helped some patients. H1 Benadryl, H2 blockers, Tagamet, Zyrtec, and Gastrocrom, Nasocrom, Singulair appear to calm the bladder and the gut. Some patients believe that H2 blockers work better for urinary symptoms than H1 blockers. These can all be found in the allergy aisle of your local drugstore. Antispasmodic medications. Patients who struggle with spasms of the bladder wall often respond well to antispasmodic meds. Ditropan, known as oxybutynin, or Detrol, tolterodine, act to relax the smooth muscle of the bladder wall to reduce urgency and frequency. Unfortunately, anticholinergic medications like these are not recommended for long-term use due to the risk of cognitive decline, dementia, and Alzheimer's. A popular alternative, mirabitril, known as mirabegron, does not carry the same risk, but it can be much more expensive. Uracid, methenamine, acts as an analgesic, antiseptic, and anticholinergic. Levsin, also known as hyoscine, can be used to calm bowel spasms and IBS. That's what I used when I had really bad bowel spasms. Urel, which is hyoscine sulfate, is a prescription med to use to relieve pain, urgency spasms, and inflammations. And Urostat is an over-the-counter analgesic and antibacterial that works to help reduce burning, pain, urgency, and frequency. Analgesics, bladder analgesics help to numb the bladder wall, like Pyridium is a prescription medication that relieves irritation, reduces burning, pain, urgency, and frequency. It is also available in the over-the-counter formula known as Azo bladder pain relief tablets. This type of medication is only intended for short-term use. Muscle relaxants. Patients responding with pelvic floor tension may benefit from skeletal muscle relaxants. Many physicians prescribe muscle relaxant suppositories, which, per Dr. Robert Evans, pose fewer risks than oral administered medications. Valium, diazepam, is effective on both skeletal and smooth muscle. It may also act as a sleep aid for patients with nocturia. Valium can be compounded into a vaginal or rectal suppositories, which may help prevent exercise-induced pain, pain after intimacy, and chronic pelvic floor tension. Flexeril cyclobenzaprine is a muscle relaxant that works by blocking pain sensations that are sent to the brain. Like Valium, this medication can have a sedating effect and is usually used at night when you can stay comfortably at home. I took a quarter of a Flexeril last night, as a matter of fact. Baclofen is a non-sedating muscle relaxant that can be taken during the daytime hours. It works by blocking nerve activity in the part of the brain that controls contraction and relaxation of skeletal muscle. Baclofen can be used orally or in a suppository to relax the pelvic floor. Anti-seizure meds. Anti-seizure medications can calm the central nervous system windup. Neurontin, known as gabapentin, can calm hyperexcitability of the nerves in people with chronic pain and neurogenic conditions such as IC, chronic prostatitis, IBS, and fibro. It not only calms the sensitization, it also calms the spinal nerve damage, which generates the neuropathic pain and inflammation in the bladder. Patients must start this medication with small doses. Side effects include sleepiness or dizziness, other nervous system effects, and water retention. Patients are advised to stay well hydrated, and although rare, some patients report a worsening of their IC symptoms after taking an anti-seizure meds. Hyperbaric oxygen therapy. Hyperbaric oxygen is not yet in widespread use for IC, but a small number of studies have shown success, particularly for patients struggling with Hunner's lesions. Patients are required to sit or lay in a special chamber that is pressurized, allowing for their lungs to gather more oxygen. This abundance of oxygen is then distributed throughout the body where it helps to fight infection and promote healing. And for anybody who's just come in, I'm reading the treatment chapter of our book, IC 101. And then I will sum this. We're almost done. You know what? I'm going to stop there, and we'll save the treatment of pain for our next meeting. All right. So anyway, back in the day, for the last 6-7 years, we've been using this stepwise system, 6 steps of treatment. They wanted you to do the easy stuff before you do the dangerous stuff. They wanted you to just use the stuff that had the lower risk of adverse event before you use the stuff that had significant adverse event like cyclosporin or Interstep. Now, a lot of what I've just read has been changed in our new guidelines. So our new guidelines are saying some of the same thing. Don't do the hard stuff until you do the easy stuff. Right? And the new guidelines recommend diet, supplements, all that sort of stuff in self-help, water, dilution, making sure you're drinking plenty of water, all that sort of stuff. Self-help matters. Self-help is the foundation of care. The patients who do the best are the patients who embrace that you have a lot of control over your symptoms at home. Okay? So following the diet, doing the relaxation, working on stress management, working on anxiety management is important. If you don't work on it, then you're shooting yourself in the foot, for lack of a better term. What's surprising about our new guidelines is that they only have 2 recommendations. Only 2 recommendations. Every other treatment are options based upon your subtype. The 2 hard and firm recommendations now by the AUA is check the pelvic floor, and if the pelvic floor muscles are tight, immediately send that patient to pelvic floor physical therapy. No waiting, because we now understand the long-term toll of tight pelvic floor muscles on the pelvis and on the bladder. And so for new patients that are working on getting diagnosed at this point, they should check your pelvic floor at that very first appointment. And if they are tight, you are to be immediately referred for pelvic floor physical therapy. And again, I was just working with somebody last week who had done almost everything except for pelvic floor physical therapy. And they had pelvic floor tension. We went through their symptoms. Yeah, sciatica, pelvic floor. Can't start your urine stream, tight pelvic floor. Pain with intimacy, tight pelvic floor. Pain while traveling, tight pelvic floor. And this person wanted to do supplement or something else. And it's like, wait. They've told you you have tight pelvic floor muscles. What are you doing about it? And her answer was nothing. And I went, well, that's a mistake. Because of all the treatments ever studied, the one treatment that was the most effective was pelvic floor physical therapy, and I'm living testimony to that. So AUA says, again, check the muscles. If they're tight, send the patient to physical therapy immediately. And then the other one is if you suspect that patient has Hunner's lesions, let's say they have a lot of blood in their urine, then look for the lesions and treat them immediately. No more waiting. Lesions respond beautifully to lesion treatment. The number one cause of long-term unremitting pain in the typical IC patient are lesions that were never treated. And it's almost a crime for a doctor to do a hydrodistension, find lesions, and not treat them. That's why when you're ever going to have a hydrodistension, you always ask, if you find a lesion, what are you going to do about it? And if they say nothing, you're going to say, why? That's an opportunity. It's an opportunity to treat. I don't want to have a hydrodistension again. If you can treat something, do it. Inject it with the steroid, and you can come to our website and learn more about those treatments here. All of the other treatments, the antidepressants, the bladder installations, the cyclosporin, the neuromodulation, etc., those are options, and they're options that only apply to specific subtypes. So I'm going to have to rewrite the treatment section of that book this summer. What else? Well, I mean, that's the big change. So anyway, well, listen, guys, we've been going for 3 hours. So let's do a last call for questions. Hold on a sec. Judy Magner, I can agree. It's miserable, and combined with IBS and IBC, it's a difficult road. And Loretta's already gone. Darn it. Thank you, Loretta. Amy says, yes, very bad breath for 24 hours after DMSO. Absolutely. Diane says she's feeling overwhelmed. Diane, if you'd like to talk, please give us a phone call. I'd be happy to talk with you. You could sign up for some diet coaching with Julie Beyer. That's an option. Excellent. All right, guys. Well, listen, let's call it here. You got to do your homework. For 30 minutes a day, I need you to do something for your spirit and your soul. Find a quiet place. Just do something that will make you feel good, whether it's going and taking a walk among the redwoods, going to church, whatever floats your boat. Take some time to give yourself some comfort. For 30 minutes a day, I need you to do something for your bladder or something for your muscles. So get down on your yoga mat and do your stretches, do your internal one, or make an IC friendly meal. For 30 minutes a day, I need you to read something. For God's sake, we've got new blogs on our website virtually every week. And what all we're trying to do is to educate you and make you more informed. You can read a blog. And mostly for every day, I need you to laugh, because pain accompanied by laughter is minimized by the brain. So do things that make you laugh and get out of the house, walk, try to do it every day. Nature is healing. Teresa says, I have trouble riding in the car. Vibration and spasm severe. Yeah, I know, hon. That's my pelvic floor exactly does exactly the same thing. But that was before I did pelvic floor physical therapy. Now that I've done pelvic floor physical therapy, my muscles are much, much better. I obviously, how long have I been sitting here? For 3 hours. I have not needed to go to the bathroom or anything at all like that. My pelvic floor, I will be stiff when I stand up, but my muscles are much, much better with proper muscle work. So it's very normal for riding in a car to trigger pelvic floor spasms, and there is hope. We have hour-by-hour rescue plans for pelvic floor spasms on our website for pelvic floor flares. If you come on over to the IC Network website, which is icnetwork.org, and you sign up for our free newsletter, you download as a gift from us our flare management guide. All right? All right, my friends, be well. I wish you well. Have a wonderful week. May good things happen every single day for you. Remember your strength. Remember your power. Remember that you deserve the best in life and the best care ever. Don't hide because you have this. There's no shame or blame struggling with pelvic pain. Ask for help. If you need some help, ask for help. All right. And if you want to ever talk, you're always welcome to call the IC Network. I do answer the phones. I answer the corporate line, and I answer the patient education line. If you're trying to place an order, you would go to the order line. And if you found this helpful, please think about becoming a member of the IC Network so you can get our magazine. This was our fall magazine. The winter magazine is almost done. The IC Optimist, where we put some of our best content right here. You can get that for $25 a year by email, and in print. If you want it mailed to you, it's $50 a year, because printing is really expensive right now, because paper is really expensive. So anyway, all right, you guys, I'll see you later. All right, Facebook's gone. All right, you guys, see you later on YouTube. Be well.